Hello, my name is John Fung, and I'm going to
him that in the current ILTS he was invited to talk about ethics and history, and he said that once you are invited to talk about ethics and history, that means you have officially grown old. So this is a recorded talk that was sent by him, and kindly
for high.
we would request that we had a complaint from one of the audience that there was a lot of echo in the Zoom, so kindly take care of that as well. Thank you.
Cholangiocarcinoma. Hello, my name is John Fung, and I'm going to talk today about liver transplantation for Hilar cholangiocarcinoma. So, in contrast to the distal extrahepatic and intrahepatic cholangiocarcinoma, I'm really going to focus on the experience with perihilar or Klatskin's extrahepatic cholangiocarcinoma. And primarily, these are lesions around the confluence and the proximal common bile duct or hepatic duct to the level of the cystic duct. You can see the Bismuth-Collette classification of the bile duct tumor location, type 1 through type 4, is shown here. The AJCC Hilar cholangiocarcinoma edition, the 8th edition in 2018, specifies the staging according to the TNM classification. You can see the classification for tumor based on the depth of penetration of the tumor, either in situ as a IS or in situ T1 lesions confined to the bile duct wall with extension to the muscular layer, T2 being outside of the wall of the bile duct, and differentiating 2A from 2B based on the level of penetration either into the adipose tissue in the hilum or directly into the hepatic parenchyma. T3 lesions being involved with either the portal vein or the hepatic artery in the hilum, and T4 lesions being involving the main portal vein or bilateral branches. You can see the lymph node status, N0 being no lymph nodes, N1 being 1 to 3 lymph nodes, N2 being 2 to 4 or more. Generally, these are found within the celiac and aortic drainage systems, and then distal metastasis M0 and M1. So the 8th edition HJCC shown here with really the 4B being those with distal metastasis as being defined in the 4B, 4A being lymph nodes that are in peripancreatic celiac or aortic location, and you can see the other ones based on the T lesion alone. So management of patients with hilar cholangiocarcinomas really shown here. This is from the Mayo group. You can see they based on the stage of the disease, obviously stage 4B, distal metastases or proximal distal lymph node metastasis being poor candidates for surgical, would go on to be treated with the best standard of care or GEM-CIS or in a clinical trial. Those are good surgical candidates, either bismuth Collet type 1 or 2, type 3, and those were type 4 as shown in this algorithm. Those that are potentially resectable would undergo biliary drainage if the remnant duct is obstructed, portal vein embolization, or other mechanisms to allow for contralateral lobar hypertrophy, and then using neoadjuvant chemotherapy in appropriate cases, either with GEM-CIS or 5FU, depending on the type of protocol that your institution uses. Resection of the common bile duct for type 1 or 2, and then ipsilateral hepatectomy with common bile duct resection and a Roux-Y with a regional lymph node adenectomy. So the reason that resection, as you know, is a poor option is because of the proximity of the bile duct to the parenchyma, to the vasculature within the portal triad. You can see in this figure. And so most patients who present with hilar cholangiocarcinomas are not resectable. Even when resectable, you can see the R0 resection in this article experience with a median survival of only 43 months compared to R1 resection of 24 months. Therefore, long-term survival greater than 5 years, at 5 years, is less than 30%. This is summarized in this collection of studies that show that even in spite of selection and reasonable R0 resection in anywhere from about 60 to 80% with liver resection, you can see the overall morbidity and mortality are quite prohibitive. And the overall survival at 5 years is anywhere from 20 to 35%. So this is the algorithm of the Mayo Clinic looking at the workup of a patient with painless jaundice with perihilar cholangiocarcinoma with cross-sectional imaging, then endoscopic retrograde cholangiography with brushings, looking for a positive cytology or FISH, the fluorescence in situ hybridization, and then those patients with abdominal stricture with positive cytology would undergo EUS, endoscopic ultrasound, for assessment of the cholangiocarcinoma status with lymph node biopsy, and if operable, consider surgery. If inoperable, then consider transplant. This is so their algorithm is shown here. The evolution of the protocol for the liver transplantation for Hilar cholangiocarcinoma started from early experiences at the University of Nebraska, and then really made much more regimented by the Mayo Clinic. And so their diagnosis, as I mentioned, either a positive cytology, transluminal and not percutaneous, with brush cytology, or a fish stain with polysomy and elevated CA19-9, Bass lesion on cross-sectional imaging with a radial tumor diameter of less than 3 centimeters, tumor confined to the biliary tree without at the level of the cystic duct or more proximal. In patient with a PSC, then these patients would not be also considered a resection candidate, but instead be candidate for liver transplantation. Exclusion criteria include those patients with prior abdominal radiation, those patients that have had a transperitoneal biopsy, as I mentioned before, other presence of intrahepatic metastases or extrahepatic disease, presence of lymph node metastases, and this would be detected by imaging and or endoscopic ultrasound, which is indicated as part of the evaluation in all patients with age range between 18 and 70. The protocol calls for neoadjuvant therapy in the form of 5-FU fluorouracil, is shown dosing there with external beam radiation, followed by transcatheter radiation or external beam radiation, depending on the protocol, exploratory laparotomy prior to transplant to rule out lymph node metastases or peritoneal spread. These patients would then, if negative, would go on to oral capecitabine until they are transplanted. So the early experience was first reported with a small series right from the Mayo Clinic, and then in a subsequent study, which is a multi-center study, which I'll review with you in just a minute. So the initial experience that was published in 2006 showed a overall 5-year survival rate of 76%, which is quite good. And this was then followed up with a larger multi-center study with a total of 214 patients that were eventually transplanted. You can see how the numbers broke down, entered into the protocol 287. Number of patients fell out for a variety of reasons, and then 214 patients were included. And you can see here slightly less than the initial Mayo experience, but a 5-year survival rate of 65% compared to what I said before, 76%. But at 10 years, a 60% survival rate. So very good outcomes. If in a retrospective analysis, those patients who fell within the Mayo criteria that I outlined before had a 5-year survival rate of 72%, and a 10-year survival rate that was close to 67%, whereas those patients who fell outside of the Mayo criteria had a 5-year survival rate of 40% and a longer-term survival rate that was closer to 30%. Those patients who fell out of the protocol, I mentioned before, that could not get a transplant, you can see within 2 years, almost all of them had died, and overall 1 year, a median survival rate of only about 1 year. Factors associated with post-transplant cholangiocarcinoma recurrence those patients who had de novo Hilar cholangiocarcinoma versus those patients who had PSC associated Hilar cholangiocarcinoma. The PSC patients were tended to be have better outcomes. Their tumors were tend to be smaller. And those patients on pathology had perineural or lymphovascular invasion did worse. Patients that had elevated CA19-9 greater than 100 at the time of transplant did worse. Those that had encasement of the portal vein, obviously those patients had residual tumor on the explant specimen in spite of the radiochemotherapy that I showed you before, also had poor outcome. Patients with lymph node involvement, older age, larger mass size, and those patients that had to wait longer for a transplant and had a prior cholecystectomy. Now, one of the lessons to learn that was learned from this experience was that the use of the neoadjuvant radiotherapy increased the post-transplant vascular complications, and this was summarized in a paper from the Nebraska series, showing that those patients that were transplanted for Hilar cholangiocarcinoma that underwent this neoadjuvant radiochemotherapy had a hepatic artery thrombosis rate that was 19% versus 4% in the non-HCC controls. I mean, the non-Hilar cholangiocarcinoma controls, and portal vein complications, which were primarily stenosis, at 37% versus 8.7% in the non-cholangiocarcinoma controls. So this did increase the technical complication rate, and this was summarized in a multi-center review retrospective analysis from the Belgium, Dutch, and French groups. And you can see that those patients had neoadjuvant therapy, or NAT, had a very high early graft loss within 1 year, a marked decrease in patient survival, primarily due to vascular complications. And those patients then after that had a very flat curve versus those patients who did not get neoadjuvant chemotherapy, who did better in the first part because of non-technical complications, but had a higher recurrence rate than the patients that had neoadjuvant chemotherapy. So the Mayo Clinic recommends several techniques to reduce hepatic artery thrombosis rate, including the use of arterial conduits for vascularization of the allograft. So one question that arises in the review of these outcomes, comparing liver transplantation with resection, is in a patient with, say, stage 2 and stage 1 cholangiocarcinoma, would these patients be better off with a liver transplant versus resection? Or in other words, those patients, because of a high risk of recurrence after resection, or have a perhaps uncertainty whether an ARDS or a resection could be achieved, would be better off with the liver transplant. So the Mayo group again looked at their resection outcomes versus their transplant outcomes. You can see 99 patients in this group that underwent resection, 54 that had a liver transplant. Otherwise, they had obviously some differences in the characteristics. Lymph nodes were more likely to be found in the resection patients because it was a contraindication in the transplant patients, and tumor sizes tended to be larger in the resection patients, as well as a higher percentage of poorly differentiated cholangiocarcinoma. Survival rates were better with the liver transplant than with resection, but in you can see this here, the overall survival curves in resection versus liver transplant. But what was interesting were those patients who actually were able to achieve a R0 resection with no nodes have a very similar survival rate to those patients that had a transplant. And so the recommendation is that if you think you can achieve a R0 resection in a patient without lymph node involvement, then those patients would be better off with a transplant. This is an analysis of a variety then of different studies that have utilized some form of a neoadjuvant therapy. And you can see here the author, the year, the center from the transplant, the patients that underwent transplant of that total number, and the overall 1-year survival and 5-year survival. And you can see that over time that there was some improvement in outcomes with about a 50 to 60 to 70% survival rate at 5 years in those patients that underwent transplant with a neoadjuvant protocol. In a meta-analysis looking at these and other studies, 20 studies that had 428 Hilar cholangiocarcinoma patients that underwent transplant, they had a overall survival rate without neoadjuvant therapy that was 71, 48, and 31% versus those patients that underwent a neoadjuvant protocol at 83%, 6% and 65% survival rate at 1, 3, and 5 years. So the recurrence rates were markedly decreased at 24% with at 3 years with neoadjuvant radiochemotherapy versus 52% that did not receive that. So in conclusions, patients with clearly resectable de novo Hilar cholangiocarcinoma should be treated with resection because there is no evidence to date that they would fare better than neoadjuvant therapy and liver transplant in those patients with clearly resectable node negative cholangiocarcinoma. Patients with locally unresectable de novo cholangiocarcinoma that meet transplant criteria should undergo consideration for neoadjuvant therapy and subsequent liver transplantation. Survival after initiation of transplant of neoadjuvant therapy and subsequent transplant clearly justified to use a deceased or living donor. In addition, the decision to proceed with resection or liver transplant in a borderline resectable patient, these are primarily stage 3 patients, really will be determined by the center's own philosophy and ability to either do resection and obviously lymph node positivity, as well as the availability of a living donor graft or a deceased donor graft. And then I think there are several questions that are still out there. This is the BILCAP study that looked at the use of adjuvant capecitabine following resection of biliary tract cancers. As you know, this randomized prospective study showed that patients who got capecitabine post-resection had a significantly improved survival with an overall 2-year survival rate of 70% versus 60% in those that did not receive the adjuvant chemotherapy. And so the question of using adjuvant chemotherapy post-transplant still has not been addressed. The other thing that I think is of interest is the evolution of targeted therapies in biliary tract cancers. As you know, there has been a huge amount of work, particularly in their arena of intrahepatic cholangiocarcinomas, where the mutation profile, as you can see here, is shown with a high percentage of patients with the FGFR2, the fibroblast growth factor receptor mutations, as well as the IDH1, a number of other types of mutations, including the P53. But the Klatskin's perihilar tumors having a markedly different profile, really dominated by KRAS and P53, as well as SMAD4 mutations, where we don't really have targeted therapy, but still we suggest doing genomics of the tumors in order to identify those patients where there may be targeted therapy. So future questions: is there a role for adjuvant chemotherapy post-transplant? Is there a role for targeted therapy in the algorithm for liver transplant? What about in the era of immune checkpoint inhibitors? Is there any benefit incorporating that into a neoadjuvant protocol like we have been for hepatocellular carcinoma? And finally, because the KRAS as well as the P53 and other mutations do signal through mTOR pathway, what is the role of mTOR inhibitors in liver transplantation for patients undergoing transplant for Hilar cholangiocarcinoma? So thank you. I think this is still an exciting area in spite of what looks like to be a relatively solid Mayo protocol. I think there are areas that we can still refine. Thank you for your attention.
Well, thank you very much. Now, the next topic is management of indeterminate biliary strictures, and we have the speaker is Dr. Samir Zar. He is a PhD. He earned his PhD from St. George's Medical University, and he has expertise in advanced EUS and ERCP, and is currently the lead consultant interventional gastroenterologist and GI cancer lead at Royal Marsden, London. Please. This will change the slides, and this is the pointer. This is the pointer.
Thank you. First of all, I would like to thank Dr. Usman Ojla, Dr. Usman Ojla and the management team at PKLI for organizing this wonderful event, and it's been a pleasure to be here. He has tasked me to talk about management of indeterminate biliary strictures. And when I think of indeterminate biliary strictures, I think about assessing the stricture and then treatment. And when you look at assessment, initially it's, as we all do, clinical assessment, look at the imaging, and then proceed to endoscopic evaluation. The treatment, I'm not going to dwell on that too much because there are many speakers who have come before me or coming after me to talk about that. So dealing with an indeterminate biliary stricture, what do you think? Well, I always think of an indeterminate biliary stricture as a malignant stricture until proven otherwise. But simultaneously, you should also explore possibility that it could be a benign entity. So here is the differential diagnosis. Malignant, this is about cholangiocarcinoma, so that's top of the list here. But pancreatic adenocarcinoma, neuroendocrine tumor of the pancreas, gallbladder cancers, metastasis to pancreas, we see a lot in our unit, renal, melanoma, breast, lymphoma, hilar lymph node, METs, and then peri-hilar infiltration, especially with things like ovarian cancers, we see a lot. Peri-ampullary or ampullary carcinomas. And then the benign list, it's not complete, but you think about primary sclerosing cholangitis, Meritzi syndrome, acute or chronic pancreatitis, inflammatory stone disease. I think that is one of the main differentials when you find a difficult to diagnose lower CBD stricture. And then not to forget about the autoimmune conditions such as the IgG4 related sclerosing cholangitis or IgG4 or autoimmune pancreatitis. And then TB, you probably see that more in this area than we see it in UK. And I think there was a very good case of peridocal varices yesterday in patients with portal hypertension, especially if there is a superior mesenteric vein occlusion. So what does pre-endoscopy assessment include? Well, you need to think about, is this patient had a surgery, post-polycystectomy strictures, transplant strictures we have seen yesterday. Has the patient had pain, could be an inflammatory process, weight loss, and then you can always do IgG4 serum levels. Think about whether or not the patient has got any bowel symptoms, could it be IBD? We all do CA19-9 in indeterminate strictures. We always send for IgG4. And then invariably, you need to proceed to cross-sectional imaging, which should really be a CT scan pancreatic protocol, as well as an MRI of the pancreas and the liver with MRCP sequences. And then in some cases, we would also do a PET scan in advance as well. And we discuss all these indeterminate strictures in our MDT before proceeding with interventions. Usually the next step is to proceed, especially if the patient is jaundiced, obstructed, to go on to do ERCP, and at the same time obtain some sort of diagnostic tissue. And this usually involves taking a cytology. That is the standard practice, and many of us now also take biopsies at the same time. However, I just want to bring this as a reminder that sometimes you proceed directly to surgery if you can't get a diagnosis. But you have to remember that up to 25% of the patients who are operated with indeterminate miliary, but presumed malignant, would have a benign disease. So it has its own comorbidities, mortality of these surgeries, but also at the same time, you have to balance it against that how much you can delay, because a delay in diagnosis can lead to progression from an operable to an inoperable disease. And that is why it's important to deal with these things in a multidisciplinary team. So you find a stricture, something similar, you go on, proceed with ERCP, brushing, biopsy, and the result, we all see this. It comes back as cytology, scanned cellular material, there is cellular atypia, not diagnostic. Usually we discuss an MDT, more often than not, we'll be asked to go back and repeat the ERCP. And then we do that. And sorry. Here, I just want to point out this recent study. This was from China, where a multi-center randomized control trial looking at, and I think this question was brought up yesterday as well, how many times you brush a stricture. And they randomized patients into 10-time passes, 20 times, and 30 times. And what they found was that patients who they did brushing 30 times, significantly more, you got positive result as compared to 10 times. So 38% versus 57%. The only other thing they found was that the stricture length is also significant for, and that makes intuitive sense, that because it's more advanced, you get more tissue. So I think the answer is the more you do the brushing, the more likely you will get the answer. Then intraductal biopsies versus brush cytology. If you look at the sensitivity of the brush cytology versus intraductal biopsies, they're both sitting at around between 40 and 50%. But if you combine the two, you can push it up to 60%. So I think it's worthwhile when you're in there to do a biopsy at the same time. It can be challenging. I think if you do a good sphincterotomy, you are able to push if it's a very low stricture, it can be difficult. But if it is in, mid or upper third of the bile duct, you can take biopsies. I use standard biopsy forceps. Now there are wire-guided biopsy forceps, which are smaller, but are available, and you can pass. I always leave a guide wire, which helps me direct the forceps up. So you do that, and then the result comes back again, showing atypia C4, highly suggestive. And we all see this. This happens to all of us who do ERCPs. Well, here you need to think about, you're delaying a diagnosis, there's a cost escalation for the patient, and both the patient and the physician can start getting frustrated. What did we do in the past? Well, we'll have a heart-to-heart discussion with the patient, try and convince them to have another ERCP. And then if they still don't agree, blame it on the pathologist, and then try and convince them. But I think now we don't do that. We have got other multimodality approach, which is now available. So you think about doing an EUS, if it's a lower bile duct stricture, or you do a cholangioscopy, and we have seen cholangioscopy being performed yesterday. There are ancillary tests, FISH or fluorescence in situ hybridization. Our unit, which is a cancer center, we don't do this because our surgeons or oncologists would not accept the result, but other centers would accept. If there is polysomia on fish, then they would proceed with treatment based on that. Then, genomics is another thing which is coming up, and I think that there we do have, and also circulating tumor DNA in the blood, especially in advanced cancer, is something that we are looking at our unit as a diagnostic modality. Then there is also advanced imaging. I'll briefly touch on that, but that is more to do with in the setting of research. So what test would you do next? As I said, for lower bile duct strictures, usually best thing is to perform in the US. You're more likely to pick up a mass. You can put a needle into the stricture as well, because even if it is malignant, you're not going to seed the tract. However, for upper bile duct or hilar strictures, it's better to do cholangioscopy, and we'll talk about that. Now, what are the pros for endoscopic ultrasound biopsy? You can see even if you do, there's a stent in the middle, and you can see this thickening around the bile duct. And you can obtain tissue sampling, and you can diagnose patients with cholangiocarcinomas. It is certainly superior to cross-sectional imaging for picking up small tumors. And tumors as small as 4 and 5 millimeter can be picked up, which may be missed on MRs and CTs. And also, if you look at it, EUS-FNA compared to ERCP biliary cytology is superior, 75% versus 56% in making a diagnosis. So, plus if the patient does not require biliary drainage straight away, they're not jaundiced, they're not cholangitic, then I think EUS, you can avoid doing an ERCP, just go straight to EUS. I've also already mentioned, so for distal strictures, you can use it in proximal strictures, but mainly we use it for diagnosing if there are lymph nodes to do a biopsy. It's difficult to get to the actual stricture itself. You may have a blood vessel in between the probe, maybe technically difficult to get high up there with the EUS scope. Also, if you are in a center which offers transplant, you can render the patient unsuitable transplant due to the seeding of the tumor. So they don't like doing it at the hilum. The next thing is the single operator digital cholangioscopy, the spyglass. It is maybe helpful to diagnose an alternative diagnosis. There may be a tiny stone there. There may be, inflammatory diffuse changes, which would put you more towards an inflammatory condition like IgG4 or PSC. And then there are various characteristics which have been described visually, which can make a diagnosis or help you think that this is likely to be a cholangiocarcinoma. But most importantly, I think where cholangioscopy now is that you've got spy bites. You can put biopsy forceps through the spy scope and take biopsies. If you look at just the visual diagnosis, and this study shows that the sensitivity is about 74% or 73%, whether or not the person who is doing it is blinded or unblinded to the diagnosis. So not great. And specificity is no better. So still, just a visual diagnosis cannot be used to make a diagnosis of cholangiocarcinoma. Whereas if you do intraductal biopsies, these two studies, they were published in 2020. You can see that the digital single operator cholangioscopy biopsy versus brush cytology in indeterminate stricture, the sensitivity for spyglass is 68% versus 21% for cytology in that study. And similarly, if you add on the cholangioscopy assisted biopsy to cytology, the sensitivity can go up to about 81% from 47%. So we all know tissue is the issue. And we've talked about the USFNA, cholangioscopy, fluoroscopic, endoscopic guided biopsies, biliary cytology. You can also think about percutaneous biopsies. We have our IR colleagues. Sometimes we rely on them to help us. They can obtain core biopsies, needle tract seeding 2%, and they need to have a visible target to do a biopsy. However, I think in the era of EUS, the use of IR-guided percutaneous biopsy in our unit, at least, it's going down significantly. And don't forget that the patient can send me directly to resection, and that provides you the diagnosis. You have to counsel the patient that it could be benign, and they have accept, and you've gone through the loop, then I think that probably could be something of a lifesaver for the patient. So other ancillary approaches, confocal laser endomicroscopy. It's something that the Salvisio company has brought out. You use tiny probes, inject fluorescein, and do real-time histology effectively. But it is operator dependent. I think it's got low specificity. You look for various features, papillary formations, abnormal blood vessels, etc. There's a lot of inter-observer variability, and I don't think it's ready for prime time yet. Intraductal ultrasound, I won't touch it in because I think this topic is being covered later on, so I'll leave it. But suffice to say that if there has been biliary intervention, it can produce false positive results. So I touched on the next generation sequencing. Again, it's part of the research and would probably provide hope. There are BILI-seq testing, and you can see that it can increase the sensitivity to 73%. And specificity up to 100% compared to the standards that we use, which is only 48% sensitivity. So what are the take-home points? Take-home points is always suspect a cancer in a patient with an indeterminate tumor. And that you should be guided by your assessment of pre-test probability. What was the clinical presentation? You should think about a multimodality tissue acquisition, which is more likely to be successful rather than a single cytology. Cholangioscopy is really helping us, and it's changing the paradigm of diagnosis, and we are using that more and more. EUS has a place in the lower CBD strictures and also for staging Hilar lesions as well, especially in inoperable cases. Molecular markers, I think, and gene testing, this is where the future will be. And then when to say stop, when should we, enough is enough? Could 12 months of clinical stability be enough? And that's something we can think about. But you have to be careful in PSC because that does come back to bite you if you don't get the diagnosis. It's going to be slow growing. And I've seen patients after a year and a half, we've been trained, they come back with mets. So then I'll just briefly touch on biliary stenting in patients, especially if they remain indeterminate. I'm not going to talk about malignant strictures, which I think is being covered by one of the other speakers. But you need to think about things. Where's the site of stricture? Is it the lower CBD or Hilar? If it's lower CBD, you can use plastic, you can do metal. I tend to use metal once we have taken tissue samples or patient has had a cholangioscopy or EUS. You have to think about what is the likelihood of this being benign. You can choose between plastic and metal, covered and uncovered. Covered has no role across the Hilar strictures. You have to be very careful. And there is no role for uncovered in benign strictures. You also need to think about the new stents which are available, which have got large cells as compared to the standard weave stents. And I'm using more and more of these in inoperable cancers where you can put up and even in, why? Because you have to go back again and again. And these patients are living longer. Some of them are responding to immunotherapy, chemotherapy. So you should think about how you're going to stent so that you can go back in and clear the stents again. So there is a question about role of biodegradable stents. Again, this is a work in progress. So I'll just touch on the fully covered versus multiple plastic stents. This was the study which looked in chronic pancreatitis, multi-center randomized trial, and whether you put 4 or 5 plastic stents, sequentially increasing them initially from 1 to 2 to 3. And we've done this over the years. Or you go straight for a single fully covered metal biliary stent. These are for lower CBD strictures, obviously. And the study shows that actually both approaches are comparable in terms of achieving the complete resolution of stricture at 1 year. And the risks are the same, but what you do see is that the number of procedures in patients that you put fully covered metal stels is much less. They showed that at least one less number of ERCP, which has obviously got its cost. And that probably completely covers the cost of a fully covered metal stent. And this this meta-analysis of multiple studies, 8 randomized controlled trials, 534 patients, looked at various indeterminate benign strictures, and they showed that the covered SEMs were comparable to multiple plastic stents in achieving stricture resolution. Recurrence was the same, and stent migration was the same. And there was no difference in the adverse events. However, cover metal stents required fewer sessions, and they showed that it was at least two sessions less. So, you know, that I think most of us, at least from where we work, we actually proceed to metal stents fairly early on. So I'll just complete my talk here, and just with a bit of encouragement to all the budding GI endoscopists there, that the world of GI endoscopy is rapidly evolving, expanding. We need more gastroenterologists, not less. And soon you will see these signs coming up. And it says the employee shortage is so bad that long-haired, freaky people can now apply to become gastroenterologists. Thank you.
That was an excellent talk, son. And I don't know what about the baldies. I mean, who have lost their hair along the way. Anyway, so the next topic is about systemic therapy for cholangiocarcinoma, and our speaker is Dr. Adnan Jabbar. He was here yesterday, but can't be here because of some commitments. He's a professor of medical oncology at Ziauddin Hospital, Karachi, and is the president of Medical Oncology Society of Pakistan, and is dually trained in internal medicine and hem-onc from United States. So we have his recorded talk. I'll just put that.
Assalamu alaikum, everybody. Thank you so much for inviting me to give this talk today. First of all, my apologies for not being there in person. Unfortunately, I had to join for another meeting, and hence I had to cut short my trip. The topic I have been given to talk about today is systemic therapy for hilar cholangiocarcinoma. The outline that I'm going to follow is I'm going to talk about first-line therapy, followed by second-line and beyond, and also the targeted therapies that are available for the management of metastatic hilar cholangiocarcinoma. Locally advanced and metastatic hilar cholangiocarcinoma, the mainstay of treatment in this or at this stage is systemic therapy. The role of systemic chemotherapy is evolving in patients with advanced cholangiocarcinoma. To date, there is no single standard of care regimen that has consistently led to an objective tumor shrinkage and preventing recurrent biliary obstruction for more than 8 to 15 months. When we talk about first-line therapy, the trial that really to date has given us a standard of care regimen is UK ABC-02 trial. In this, cisplatin plus gemcitabine was compared with gemcitabine single agent, which was the standard of care at that time for biliary tract cancers. So locally advanced metastatic cholangiocarcinoma, gallbladder cancer, and periampullary cancers were randomized to either receiving gemcitabine alone or the intervention arm, which was cisplatin along with gemcitabine. 410 patients were randomized. And if you look at the outcome, the progression-free survival had improved in the treatment arm from 8.4 months versus 6.5 alone in gemcitabine single agent. The response rate was also improved, which went up from 16% to 26%. If you look at the overall survival, there was a clear benefit of adding cisplatin to gemcitabine with an overall survival of 8.3 versus 11.7 in the treatment arm. This is the forest plot. And if we look at it, everything favored the addition of doublet to the regimen as compared to single agent. Patients with, locally advanced or metastatic, patients with intrahepatic, extrahepatic, and on gallbladder, they all clearly had an advantage of adding a double or second agent to it. Also to note is that patients with good performance status, meaning ECOG performance status of 0 to 1 were the ones who benefited from it and the ones who had previously received any treatment. This regimen is well tolerated. Here is the list of adverse events, grade 3, grade 4, which were very much comparable in the treatment arm compared to the control arm, where 64% all grade 3 adverse events were in cisgem versus 65% in the gemcitabine arm. Hence, the UK ABC trial was the first trial that demonstrated statistically significant clinical and survival benefit in advanced biliary cancer. This gain was not at the expense of added toxicity, and this became the standard option for all of these patients with good performance status and who did not have hyperbilirubinemia. Gemcitabine plus cisplatin since then has been considered as the reference regimen for the advanced biliary cancer. Some of the other regimens which have been looked at in addition to cisplatin is, these are those regimens which I have kind of summarized in one table. There are only 3 other phase 3 trials in which gemcitabine along with S1 was compared head-to-head with gemcitabine and cisplatin. 354 patients were randomized and they showed a similar effect in an increase in overall survival and progression-free survival when we added S1. Of note, S1 is not readily available, and this trial was conducted in Japan, where we already know that S1 is highly efficacious and gives the results which have not been reproduced in European countries. So that should always be kept in mind. The other trial which had shown similar outcome was GEMOX, gemcitabine along with oxaliplatin, and that was compared head-to-head with capecitabine and oxaliplatin. 222 patients were randomized, and the overall survival, once again, was very similar in the GEMOX and CAPOX arm, along with similar progression-free survival. The overall response rate was 25 versus 16%. Addition of anti-VEGF to GEMOX showed slightly better overall survival, but this is phase 2 data, and in order to make any inference, we would require a phase 3 randomized controlled trial to see if this trend is actually present or this is just in a phase 2 outcome where it is setting the trend. Some of the other trials were gemcitabine plus capecitabine or gemcitabine plus nab-paclitaxel, but as you can see, none of these trials did anything better than gemcitabine cisplatin, and hence none of them has really taken over with the standard of care gemcitabine along with cisplatin. The only other trial that have shown any difference or any better outcome is the TOPAZ-1 trial. The addition of immunotherapy, durvalumab, to gemcitabine and cisplatin was seen in this study. This was a phase 3 double-blinded multi-center trial where locally advanced metastatic biliary tract cancers were randomized to either received gemcitabine cisplatin along with durvalumab, or they were just given placebo. These patients went ahead to get maintenance durva after 8 cycles or placebo control until disease progression. The primary endpoint was overall survival, and once again, TOPAZ-1 showed an improvement in overall survival at the end of end of the results. So if you look at it, median overall survival is 12.8 months versus 11.5 months in placebo control. There is a 1 month advantage between the intervention arm versus the standard of care GemCis. One of the things that everybody must, and I should like to highlight, is if you look at the graph at 6 months interval, there is no difference. The two curves are pretty much overlapping each other. It is only later on that once these two graphs start separating out. So one of the things that we typically talk about is that these patients, there is something within these subgroup of patients who benefit from the addition of immunotherapy. Which patients are those? Unfortunately, we do not know of, but this is clearly a subgroup of patients which tend to then spread out as we move along. The tumor response was certainly better, 26% versus 18.7%, and the duration of response was similar in the two arms. The 9th-month response was 32% versus 26%, and at 12 months it was 26% versus 15%. This was also a very safe intervention arm where there was not much difference in adverse events between the two groups. The only additional adverse events were related to the immunotherapeutic agent, and hence there were more immune-mediated adverse events at 12.7% versus 4.7%. Hence, TOPAZ-1 was then a alternative to gemcitabine plus cisplatin, but because of the reasons that I alluded to, it is not necessarily preferred in all patients. The short-term benefit over gemcitabine plus cisplatin alone are modest, but long-term effects may be clinically meaningful for some patients only. Unfortunately, we do not have any predictive biomarker based on which we can select which patients may give us this preferential benefit. And this decision to add a very expensive immunotherapeutic agent should be based on patient's preference, financial strength, and the availability of durvalumab, which at present is hard to get and very expensive in Pakistan. We always try to strive for better outcome, and there were trials to see if anything can improve the outcome by the addition of third drug. Prodigy 38 Amibica trial answer that if you add a third therapeutic agent, FOLFIRINOX versus a doublet cisplatin gemcitabine, there is no advantage in the terms of median overall survival. Progression-free survival is also the same. The only thing that adds on is toxicity. Hence, the doublet of cisplatin gemcitabine remains to be the standard of care to date. So in our first-line therapy options, patients who have good performance status and normal bilirubin, gemcitabine plus cisplatin is the preferred regimen. Durvalumab may be an alternative, but it may be for patients who can afford it. Good performance status, but if you have persistent hyperbilirubinemia, a non-gemcitabine-based regimen can be much more effective, such as adding 5-fluorouracil along with leucovorin or fluoropyrimidine along with oxaliplatin. Patients who have poor performance status and who have extensive comorbidities, they do not do well with the doublets, and the recommendation is to give the same agents but only as single agent, meaning capecitabine or gemcitabine or S1 for that matter. When it comes down to second-line therapy and beyond, the trial that has level 1 recommendation is the addition of FOLFOX after failure on the first line. It was based on the ABC-06 trial that added this recommendation in our armamentarium. It was a phase 3 open-label trial where adult patients with locally advanced or metastatic biliary tract cancers which included cholangiocarcinoma, gallbladder, and ampullary carcinomas, were randomized to either receive FOLFOX or just active symptomatic control. And the primary outcome of this trial was once again overall survival. And this is the graph which is looking at the overall survival. Once again, FOLFOX was better than just symptomatic control, with an overall survival of 6.2 months versus 5.3 months. Adverse events were fairly similar. There was some additional toxicity due to the addition of second drug in terms of infections, fatigues, and neutropenia. Otherwise, most of them, the therapeutic as well as the control arm, was fairly similar. Some of these other regimens that have been used effectively in second-line therapies are mostly based on phase 2 data, whether the addition of liposomal irinotecan along with 5-fluorouracil or irinotecan with capecitabine, or a VEGF inhibitor like regorafenib or ramucirumab. All of these trials have shown an overall survival benefit as well as progression-free survival benefit when added. But none of them are different, so hence there is no preference of using any of these in any order except for FOLFOX, which was a phase 3 data. Molecular targeted therapies have entered. We have entered into the era where targeted agents are used more and more frequently. It is based on this information where the incidence of selective mutations in patients with cholangiocarcinoma have been found to have these active genomic alterations. There are almost 3.6 total genomic alterations per patient in intrahepatic cholangiocarcinoma and 4.4 in extrahepatic cholangiocarcinoma. Of these alterations, almost half of them has some clinical relevance for being actionable. Stopping these actionable mutations by using their specific inhibitors have been useful in providing us some control of these diseases. The alterations that have been most commonly found are B2 amplifications. They are common more in extrahepatic cholangiocarcinoma, 11%, as opposed to intrahepatic cholangiocarcinoma. BRAF mutations are common more in intrahepatic, but they've also been seen in extrahepatic cholangiocarcinoma. FGFR mutations, fusions, and amplifications are seen more in intrahepatic cholangiocarcinoma, along with IDH1 and 2 substitutions. Some of the other aberrations that have been noted but less frequently is the oncogenic NTRK fusion, which is found in less than 1%. The presence of the MSI high status or deficient MMR is also seen in 1 to 5% of biliary tract cancers, which can be used effectively for controlling these disease. Tumor mutational burden, which means more than 10 mutations per base pair, is also seen in 4% of these biliary tract cancers. These are some of the trials that show effectiveness of using these targeted agents. My pathway is a phase 2 trial with 6 targeted regimens in patients with advanced solid tumor, which potentially are actionable molecular alterations. The use of trastuzumab and pertuzumab against anti-HER2 shows that there is definitely a progression-free survival benefit as well as median overall survival benefit. This is seen more in extrahepatic cholangiocarcinomas as opposed to in the intrahepatics. But clearly, there is partial response and stable disease in patients when we treat them with HER2-targeted therapy. BRAF mutation is also found in 5%, and the phase 2 ROAR basket trial showed that when a BRAF inhibitor like encorafenib is used along, dabrafenib is used along with a MEK inhibitor, there is a median progression-free survival of 9 months and overall survival benefit of 14 months with an overall response rate of 51%. Use of immunotherapeutic agents in this type of cancer has been shown in phase 2 Keynote 158 trial, where pembrolizumab, when used in patients who have either a mismatch repair deficiency or high tumor mutational burden, gives you a median progression-free survival of 3.5 and overall survival of 2.1 months. And hence, pembrolizumab has been recommended for patients who show a high MSI status or high tumor mutational burden. The other oncogene which is present is the NTRK fusion that occurs in 0.1% of the biliary tract cancers. Use of an NTRK inhibitor like entrectinib or larotrectinib can give you a median progression-free survival difference of 13 and overall median follow-up of 25 months. Larectinib gives a median progression-free survival of 28 versus 12 months. So in summary, second-line therapy and beyond your first line, after if you have received gemcitabine or cisplatin, FOLFOX is your first choice. IV 5-fluorouracil can be replaced by capecitabine. The other agents that can be used is liposomal irinotecan, along with 5-FU with leucovorin, fluoropyrimidine or GemOx with or without bevacizumab can be used. For patients who have received GemOx as their first-line agent, which is again a very common regimen used more in Europe, then in that scenario, one can use capecitabine along with cisplatin or gemcitabine, or again FOLFIRI. I would like to make a note that in a country like Pakistan, where resources are limited, I always think about what is my second and third line regimen, as opposed to using a regimen which takes up all the drugs and put them in one cocktail, and then I do not have anything to offer in second and third line. GemOx, in my view, is for the same reason not used or preferred with in my practice, because you already are using gemcitabine and oxaliplatin, and then in second line you have limited options, as opposed to when you use gemcitabine plus cisplatin, then you have the option of using FOLFOX, FOLFIRI, and GemOx as your subsequent line of therapies, and give you many more options. Patients who can afford and can get these molecular target agents checked through NGS testing can benefit from the addition of these specific molecular target inhibitors. This is summary of what I just talked about: biliary tract cancers, which are advanced or metastatic. One who can do molecular profiling should do molecular profiling upfront. Cisplatin, gemcitabine, with or without durvalumab is the first line, and the level 1 recommendation by ESMO. For patients who progress and do not have any actionable mutation, FOLFOX carries level 1 recommendation. And for those who have any specific mutations, using a specific inhibitor has a level 3 recommendation in use. So in conclusion, for first-line therapy, cisplatin plus gemcitabine is the recommended standard of care in patients with good performance status. Patients who can afford Durva, so Durva can be added, but this should be individualized. Oxaliplatin may be substituted in patients who have a altered renal function, and patients who have limited performance status. Use of monotherapy is the recommendation. Targeted therapies can be and should be used effectively in patients who have actionable mutations. Immunotherapy, in case if there is MSI high or tumor mutational burden, which is high, and early integration of palliative care should always be in the mind of a medical oncologist. Yes, Pakistan does not have a lot of palliative care physicians, but I think it is a growing field. And in the last 5 years, I've seen a lot more happening in this field, which should always be considered when we are treating stage 4 cancer patients. I'm going to stop here, and I thank you for your attention, and we'll be happy to address any of your queries. Thank you.
Well, thank you very much. That was an excellent talk. Our next talk, the title is Role of Intraductal RFA in Hilar Cholangiocarcinoma, and our speaker is Dr. Harry Keltisidis. We welcome you here to this conference. Dr. Harry Keltisidis is a PhD in FRCP, and he earned his PhD from the illustrious Imperial College London, and his expertise include advanced EUS and ERCP. And currently he's working as a consultant hepatologist and lead interventional gastroenterologist at the Manchester University Hospital. Dr. Harry, can you please join us? Change the slides.
Good afternoon, everyone. It's a pleasure to be here. I would like to thank my friend Usman for the kind invitation to be a speaker in what turned out to be a very successful first meeting of its kind, and hopefully the first of many to follow. It's a difficult time in the afternoon for people to maintain the concentration, so I will try and be quite brief. The task I was given was to summarize what is known so far in the literature with regards to the use of radiofrequency ablation for Hilar cholangiocarcinoma. With your permission, I will slightly deviate from that mandate because there isn't really a whole lot on use of RFA specifically for Hilar cholangiocarcinoma. So I might talk a little bit more about the technique and generic use in the biliary and pancreatic tracts, and hopefully focus on the little that's out there with regards to its use in Hilar cholangiocarcinoma. So for us physicians, what is RFA? In very simple terms, we use a couple of electrodes to generate heat, and that heat is the means we use to ablate tissue. So the tissue destruction is caused by hypothermic injury, which is causing coagulation, necrosis, and we use generally alternating current with wave ranges between 400 and 500 kilohertz. And the current oscillates between the two electrodes. So we have two different types of systems, monopolar and bipolar. Surgeons are probably much more used to bipolar systems in theaters, whereas in endoscopy, we most commonly use monopolar. But the RFA catheters that are commercially available are all bipolar. So you see the prototype Habib catheter with the two electrodes. So the current is basically traveling that short distance between the two electrodes. And this is a monopolar system used to ablate liver tissue, where the electrode is basically the ablation catheter, and there's a pad on the patient's skin where the energy travels back to the generator and completes the circuit. So this is a slide from the use of RFA in ablation of the AV node to prevent recurrent re-entry tachycardia. So it's just to demonstrate the type of tissue injury caused by RFA. So this is the needle track, and the cylindrical area around that is the coagulation necrosis, which is a little bit denser. I'm not sure if that's the right term. The closer you are to the source of the energy. And perhaps more familiar to this audience, the use of RFA for ablation of either primary HCC or metastatic lesions in the liver is a very well-established therapy. And when the patient is selected properly, the efficacy is similar to that of surgical resection with fewer complications. The use of RFA for pancreatobiliary malignancy is a slightly more novel concept. So as we heard many times, pancreatic cancer, cholangiocarcinoma, very aggressive cancers with often late presentation where surgery is not really an option. So chemoradiotherapy, limited survival benefit. So there is a pressing need to develop modalities for local regional control with tumors as well as better systemic therapies. So the introductal RFA, in terms of technique, is a catheter that's loaded on a guide wire during an ERCP procedure. We localize the stricture fluoroscopically with an injection of contrast. We position the catheter with the help of some radiopaque markers, and then we apply energy according to the recommended settings, anywhere between 30 to 120 seconds, 7 to 10 kilowatts. And for longer strictures, we can move the catheter back and forth to make sure that we cover the whole length of the stricture. And finally, after the treatment is completed, there's always stenting to follow. So that's an example of application of RFA for a Hilar stricture. So the catheter is first inserted over the left wire into the left system. You see the two radiopaque markers here, and the magic is happening here between the two markers. So once that is being treated, same happens on the other side, and at the very end, bilateral metal stents are placed. The temperature, the target temperature is generally 60 degrees, and that's sufficient to cause coagulation necrosis. In the outer zones of the coagulation area, the temperatures do not quite reach 60. So, but temperatures over 40 and below 60 are sublethal, and the cells affected by those temperatures can have various different fates. They can undergo apoptotic cell death via lysosomal activation, or they can recover. And this sublethal area of RFA is, at least theoretically, important. It's been shown in ex vivo models that with subtotal delivery of RFA ablation, there is enhanced T cell, especially CD8 T cell responses towards tumor antigens with activation of the dendritic cells and that part of the cytotoxic immunity. The various theories behind that, but I think the prevailing one is that the release of antigens and epitopes in the bloodstream is causing an immunogenic effect. So besides the local effects of the ablation, there may be a systemic anti-tumor effect for RFA, but that has not been definitively proven in patient trials. So there are two main players in the field. The original catheter developed 12 years ago by Professor Nagi Habib's team at Imperial College. It's called the Habib Endo HBB. It's now owned by Boston Scientific and is distributed by Boston Scientific. And the second catheter came a few years later. It's the Elra catheter by Taiwan Medical in South Korea. So this is the original Habib catheter, which has 2 electrodes, and the much newer Taiwan catheter has 4, so a larger area of coagulation. And these are the catheters in action. Here we see the Elra catheter during an ablation of an ampullary tumor. And this is a demonstration of the coagulation effects of the Habib catheter at various time points. So this is 30 seconds, 60 seconds, and 90 seconds, which is the recommended time for each individual application. So these are the technical characteristics and the differences. I don't want to bore you with many technical details, but obviously the LRA is a much more modern kind of product. So it has a couple of safety features incorporated, and those are a stop mechanism when the electrodes are not in contact with tissue, and also a cutoff when the temperature gets over 60 degrees. So the first reported case of RFA came from Hyderabad, from Nagi Reddy's unit 12 years ago. A subhilar cholangiocarcinoma treated with RFA using the Habib catheter. And there were also cholangioscopic images showing the effects into the bile duct. Since then, there's been a relative explosion in the literature of the use of the catheter. And there is a wealth of literature, but as you can see, there are some quite significant logistical issues with the RFA literature. The studies are very diverse. Some of them have a prospective design. Most of them are retrospective. There's only one that's randomized. There's meta-analysis putting together studies which are not really meant to be together. There's a mixture of patients with different pancreatobiliary malignancies, pancreatic cancer, extrahepatic, intrahepatic cholangio, gallbladder cancer even. We're using in different studies, different generators, different settings, and 2 different catheters and different treatment protocols. Some studies have 1 index session when the patient is treated and then stented. In other studies, there's 1 index session, and then every time there's obstruction or there's another indication that the sessions may be repeated. There's difference in the stenting used, plastic versus metal stents, and also in the endpoints. What are we looking at? Survival, progression-free survival, stent patency, and even an endpoint in many studies is comparing the combination of RFA and stenting to what's considered the gold standard, which is PDT, for the dynamic therapy plus stenting. So I'm not trying to confuse you, just showing you an example of how many uncontrolled studies there are. And we can see here the different outcomes and the different endpoints of these studies. So it's very, very difficult to make sense of it all. Some of them are looking at patency, others at the diameter of the bile duct after the application of RFA, and so on and so forth. And this is a list of controlled studies up to date. So I'm going to try and focus on selected few, which probably have more merit. And this is a study by Alan Steele at Hammersmith Hospital, one of the very early ones. So obviously this is a phase 2, shall we say, trial with the aim to establish feasibility and safety. So 22 patients were treated, variable indications, again, both pancreas and extrahepatic, usually distal cholangio. And we looked at immediate and 30-day complications and 90-day stent patency. So 18 out of the 22 stents were patent at 90 days and no major complications. So we could assume that the method, the new technique, is safe to use. So this is a comparison of RFA plus stenting with PDT plus stenting, which in terms of survival at the time and still is considered the standard of care. So we know that a couple of randomized control trials confirming that PDT offers survival benefit over ERCP. This is a retrospective cohort study, 48 patients, 16 had RFA in standing, and this historical control of 32 patients with photodynamic therapy. Median survival about the same. So ERCP RFA is comparable to PDT and stenting, and for unresectable cholangiocarcinoma with fewer side effects as well. So this one is labeled as a prospective study, looking primarily at effects and adverse effects of RFA, again, in comparison to PDT in Hilar cholangiocarcinoma. At least in this study, the cohort of patients is more, well, it's patients with Hilar lesions only, and they don't include other locations in the biliary tree. So the prospective element refers to the recruitment of the patients, but then the comparison is with a retrospective historic group. So 14 RFA patients, 20 PDT, both arms received stenting. And rather unsurprisingly, because RFA is primarily a method for local regional control, the 3-month stent patency was higher in the RFA group, and the rate of complications was also lower in the group that received RFA and stenting. This one is probably as good as a retrospective design study can be. Decent numbers, 79 consecutive patients with perihilar cholangiocarcinoma, 51 bilateral stenting, and 21 RFA and bilateral stenting. And also the stenting is quite uniform. We didn't use plastic or metal. And unfortunately for the RFA advocates, it's a negative study. There's no difference in the stent patency or the overall survival of these patients. And this one came from Nanjing in China, and it's the only randomized controlled trial for RFA and stenting compared to stenting alone. 65 patients. The group of stents consists of 33 patients, and the group of RFA and stents of 32. And all of them were extrahepatic cholangios. Interestingly, they included the bismuth, the 1 and 2, and not the 3 and 4. So 21-month follow-up, and this study shows a rather significant survival benefit in this group of patients, as well as improvement in the stent patency, 6.8 months versus 3.4, and comparable adverse events in both arms of the study. So the conclusion from that single randomized controlled trial is that this approach is safe and effective and potentially offers a survival benefit in this group of patients. So not a lot out there, and certainly a lot still to be learned, but so far we know that perihilar cholangiocarcinoma is a very dismal diagnosis. There's an enormous pressure to improve outcomes, and in that context, endoluminal RFA was developed as a palliative treatment for perihilar cholangiocarcinoma. And although there's some limited evidence for improved survival and stent patency, we're in dire need of more reliable randomized prospective controlled trials data in order to define the place of RFA in the treatment algorithm of these patients. And I think the problem with the literature is that the studies are quite heterogeneous, so it's very, very difficult to compare outcomes out there. So that's an invitation to all of us in the context of perhaps multi-center collaborations to probably come up with study protocols to define the role of RFA in the treatment of Hilar cholangiocarcinoma. Thank you very much for your attention.
Thank you very much for an exciting talk. There is a quick announcement now there. An attendance sheet will be circulated. Kindly sign that so that you may be awarded the CME points. Now, the next session would be about the case scenarios, and this will be about management dilemmas. And the presenter would be Dr. Osama Bhatt, our very own young and energetic consultant transplant hepatologist. He did his graduation from Dow Medical College and then obtained his FCPS in gastroenterology and then further fellowship in transplant hepatology and worked as a research fellow in King's College London. And he has interest in HCV and transplant patients and has some manuscripts to his credit as well. Dr. Osama.
Assalamualaikum. Bismillahirrahmanirrahim. I am Dr. Osama Tariq Bhatt. I am working as a consultant gastroenterologist and transplant hepatologist at PKLI. So my presentation will be divided into two parts. First, I'll present a case and followed by some discussion points. And my apologies for the repetition of slides in the end, since it's because of the scope of the topic we are discussing. So our case is of a 65-year-old male. He's a resident of Lahore. He presented to our clinic with a history of 2 months history of loss of appetite, along with unintentional weight loss, along with the development of jaundice, itching, and clay-curled stool for the last 15 days, and which was associated with dull epigastric pain. He came up with an ultrasound abdomen which showed mild to moderately dilated intrahepatic ducts with prominent CBD, and there was no liver lesion identified. Fortunately, there was no medical or past surgical history. He was not habituated to anything, and there was no previous comorbids. The patient was married with 5 children. These were the initial investigation he came up with a total bilirubin of 28. ALT was 45 with slightly cholestatic picture, alkaline phosphatase 371 and gamma GT of 212. Serum albumin was 2.38 with a platelet count of 291. CA99 at arrival was not available, but he was hepatitis B and C negative. So we did a CT scan at PKLI, which showed an ill-defined soft tissue growth at the porta hepatis that has severely encased this porta hepatis along with the common hepatic duct, which was close to the confluence of right and left hepatic ducts, and it was extending up to the left lobe of the liver. It is also encasing and occluding the left portal vein and the left hepatic artery. Resulting in moderate intrahepatic ductal dilation, which was more marked on the left side, and there was no extrahepatic metastasis. So according to Bismuth classification, it was categorized as Bismuth 3B. So because of the bilirubin of 28 and Bismuth 3B, he was referred for PTBD, and the cholangiogram showed intrahepatic and extrahepatic biliary tract channels dilated with abrupt cutoff at the distal CBD. The guide wire and CAMP catheter was combined successfully, and placement of 8.5 French biliary catheter was placed. So after 10 days after drainage, the bilirubin came down from 28 to 11.54 with slight decrease in alkaline phosphatase and gamma GT. And at that time, his CA99 was more than 12,000. And this CA99 level was sent when the bilirubin was 28. So he then went for surgery, which included a left hepatectomy along with caudate lobe excision, lymphadenectomy, and Roux-en-Y hepatojejunostomy. During the surgery, the findings were hilar cholangiocarcinoma and large periportal and celiac axis lymph node, and rest of the peritoneal cavity was normal. The frozen sections of margin of right hepatic anterior and posterior duct were sent, and they came out to be negative. So this is the gross macroscopy, which showed there is a tumor present in the porta hepatis with the size of 3.1 into 2.5 centimeter, and it is involving the smaller hepatic bile ducts extending along the wall and reaching the hepatic parenchymal resection margins. So on histopathology, the tumor size has the greatest dimension of 3.1 centimeter. Histopathological type was adenocarcinoma, which was well differentiated. The distal CBD margin, proximal CBD, and right hepatic duct was uninvolved. Similarly, the hepatic resection margins were also uninvolved. There was no lymphovascular invasion identified, although there was perineural invasion present. The gastric artery, perigastric, and station 8 lymph nodes all showed reactive lymph nodes. One of the lymph node periportal showed bland epithelial ductal epithelial structures. So this is a slide which is showing the dilated duct with concretion with periductal infiltrations. So grossly, the post-operative course was uneventful. He stayed in surgical ICU for 6 days and was discharged on day 14. And then he was referred to medical oncologist for adjuvant chemotherapy on the follow-up visit at 30th post-operative day. So these were the investigations. The total bilirubin after 1 month was 2.15 with a direct of 1.38, and his CA19 levels were 38.03. The patient visited the oncologist. He had no active complaint at that time, and they advised a post-operative CT scan along with CA99 levels, which was 38. So this was the post-op CT scan, which showed no intrahepatic ductal dilation, no recurrent disease process, and no free peritoneal fluid in the abdominal cavity, as well as no lymph nodes, mediastinal mass, or lymphadenopathy. I think. Oh, I haven't noticed that thing. Yeah, I think there's some fluid collection is there. Maybe this type of cyst is there. It is fluid containing. It was still present here. I think it is the size looks almost similar within 2 to 3 months. The patient received 2 doses of gemcitabine-based therapy, but unfortunately, because of COVID infection, he was lost to follow-up. And he presented after 11 months in OPD with a complaint of abdominal fullness with dyspepsia. The labs at the time of arrival was a total bilirubin of 0.9, alkaline phosphatase of 163 with a gamma GT of 151. albumin level was 3.87 and CA99 was 102. So the CT scan what was done after he was lost to follow up, it showed there is minimal biliary dilation in the right lobe of the liver with no lesion identified in the liver. Although there was a left-sided hemidiaphragm that has a 5.7 centimeter defect through which the body and fundus of the stomach was herniating into the left hemithorax. The liver has no lesions and no enlarged lymph nodes. So he underwent incisional hernia mesh repair with left diaphragmatic hernia mesh repair along with splenectomy. And post-operatively, patient developed portal venous thrombosis and ascites, which was treated medically, and he remained admitted in ward for next 15 days. So on follow-up after discharge, his bilirubin was 1.23, the direct component of 0.84. The alkaline phosphatase increased up to 1059, and the gamma GT was also raised to 379, and now the CA99 was more than 1000. So so the repeat CT scan was advised, and it showed an ill-defined, poorly enhancing growth based at the porta hepatis, which was 3 centimeter. It was completely obliteration of the main portal vein, encasing the common hepatic artery with mild intrahepatic duct obstruction. Follow-up with the oncology clinic was there, and they advised to get ERCP or PTBD for deranged cholestatic LFTs before starting chemo. So this is not the complete picture. This is the initial image which showed the right-sided biliary access was done, and later on an 8.5 French external internal biliary catheter was placed. So after the PTBD, the repeat LFT showed improvement in cholestatic pattern, and then he was started on chemotherapy 5 cycles, and he has also received radiotherapy till date. He has been following with the oncologist, with our oncologist team. This is after 5 cycles. So I have some discussion points. I think the surgeons can answer, but I think. It was a left-sided hernia. How the stomach was. So I have some discussion points. Is preoperative biliary drainage necessary for patient with jaundice? So it is routinely not recommended in the extrahepatic stricture secondary to resectable pancreatic cancer or cholangiocarcinoma. But in case of cholangitis or sepsis originating from the biliary tract, in case of severe pruritus or with the need of new adjuvant therapy, it is recommended. And what is the appropriate preoperative biliary drainage for resectable biliary bile duct obstruction, hilar obstruction? We have two approaches, the percutaneous approach and the endoscopic approach, and several type of drainage tubes, the endoscopic, the metallic stent, and the endobiliary. All the results are conflicting regarding the PTBD has a lower infection rate, but risk of portal vein hepatic artery injury, and some of the studies have also showed tumor seeding, although it is not been verified or recommended yet. Similarly, the endoscopic approach has accompanied by risk of obstructive cholangitis along with increased risk of pancreatitis, and the advantage of nasobiliary drainage is capable of obtaining characteristics of the bile. But grossly, according to the studies, if the bismuth classification is 1 and 2, ERCP is usually recommended over percutaneous approach, and in bismuth type 3 and 4, the combination of ERCP and PTBD or alone PTBD is advised or recommended. what happens, how to management of fever in patient who have already undergone biliary drainage. So after biliary drainage, if the fever occurs, then the causes mostly include the catheter trouble, which includes obstruction, bending, or dislocation. And if there is any catheter causes, then catheter is exchanged with antibiotic administration. But if the fever lasts for more 2 to 3 days, even after catheter exchange, then segmental cholangitis of the undrained segment is suspected, and additional drainage of the undrained segment is necessary. Risk factors for recurrence of cholangiocarcinoma after resection, grossly divided into the patient-related and histological related. Patient-related include history of PSC with a baseline bilirubin of more than 3, high CA19 level of more than 150, and a tumor size of more than 2 centimeter, along with the histological grade of 3, 3, 3, 4, presence of perinuclear invasion, and moderately to poorly differentiated pathological differentiation. Is adjuvant chemotherapy necessary after curative intent resection of biliary tract cancer? So if there is N0 tumor, then there in some studies show that there is no difference in survival. But some of the studies, especially the BILCAP and the SCAP3 trial, showed that there is survival benefit. Of course, when there is node positive disease, then a patient is given adjuvant chemotherapy. This is just the algorithm of stricture following hepatojejunectomy. So when the patient comes to us, we will check whether the patient has jaundice or cholangitis, or he is asymptomatic. If the patient has cholangitis, then if he is hemodynamically unstable or stable, if the patient is unstable, then we will go for ultrasound and go for PTC with drain placement. If patient is hemodynamically stable, then we go for MRCP with stricture presence going to PTC, and with no stricture going for regular follow-up. So the take-home message is early and proper imaging, including the triphasic CT scan or MRI liver dynamic, immediate referral to tertiary care facility for multidisciplinary care, case discussion in MDT, and we have to set up protocols for cholangiocarcinoma surveillance, and patient and family support for regular follow-ups is recommended. Thank you.
Can I start with the first question?
Yeah.
Yes. ये mic इनको दे दे please.
Did you consider transplant initially?
It can be considered, but usually when the tumor size is less than 3 centimeter and there is N0 nodes, then usually resection is preferred.
Osama, so I have a few questions. So first of all, I would like to kind of congratulate you for presenting this case, because generally as surgeons we try not to bring these type of things onto the symposium or conference. But anyway, I have a lot of questions. I'll try to be specific. So you have a patient, low albumin, CA19-9 is very high. You stent him, that's fine. Jaundice is still there. You had a bilirubin of around 10 when you went for the operation, right? And the CA19-9 was still very high. The albumin,
It was not checked preoperatively. Immediately it was checked when the bilirubin was 28, and it was more than 12,000.
After stenting, before the operation, it was checked again, right?
No,
Or it was never checked?
No, it was never checked because the gap was almost 2 weeks.
Okay, and the albumin was still low. So you started with 2 point something, and I think it was still around 3-ish. So any role of nutritional rehabilitation in this patient?
Yeah, nutritional rehabilitation is necessary just to increase the healing of the wound and to proper. But I think with the presence of T3B lesion on imaging, and because of the other prognostic factors, it was decided to proceed for surgery.
PET scan?
With the CT scan showing no features of any metastatic lesions, I don't think it is usually recommended.
But it's good for every cancer, actually.
It is more necessary.
You are not able to kind of see much. But I think there's no harm in going for a PET scan, just to kind of reevaluate and see. Because he had a recurrence retrospectively, if you see it, he had a recurrence. When And the hindsight, everybody is wise, but the thing is, with a very high tumor markers, would you not kind of think maybe we are missing something? No. Pre-operatively, it was in thousands. No, because if we see the scenario in a broader context, when a small tumor sitting there with no nodes, yes, it is very kind of tempted. You want to go in and do the surgery, but with just keeping an eye on the very high tumor markers, would you not like to kind of go for a PET scan?
But because of cholestasis.
Always predict that there are second.
Not always. No, I agree.
How frequently would you go for a PET scan if you had a, and what would be the cutoff level? Let's say
In
600,
every case,
1200,
CA
1000.
19-9, I would go for a PET scan. We have seen so many metastases in patients with high CA19. There is no question about PET scan in this type.
And then that was only picked up on PET scan.
If it's not on CT, then you're going to go for PET scan, right?
नहीं वो कह रहे हैं कि
Metastatic patient. That's a different thing.
Just one clarification as well. This question and answer is for the whole session as well. So one of the speakers, you can ask questions about oncology. Some of the speakers are present in person here. So this time allotted is for all the speakers.
I just want to ask the radiologist, because yesterday we also had a discussion about using PET scan at the staging stage, and I think there was no clear answer, and there was no clear cutoffs of anything that we should go for a PET scan. So the radiologist can comment on that.
Say, can you repeat your question again? Sorry.
PET scan as a screening tool for someone with hilar cholangio with no obvious metastasis on a CT scan.
I'm not sure. I'm not sure about the answer. Najam?
Me neither. I wouldn't give you a figure as far as accuracy of PET scan is concerned and its association. We have not biopsied it up front, so we don't know whether it's a high grade or low grade. So you would expect PET CTs usually become more positive with high grade tumors. And I think we suspected a lymph node up front on the baseline imaging. I think that would have actually called up given the high level of CA 19.9. So the combination of the two probably would have triggered the use of PET scan.
I think that's the right approach, because I missed that there was an enlarged lymph node. So if there is an enlarged lymph node, CA 99 is very high, and you are planning surgery, I think that makes a case for a PET scan.
There was a prominent lymph node along approximately 1 centimeter, and otherwise there was no lesions on the chest imaging and no other lymph node that was identified. So the CA99 level was 12,000 at the time when the bilirubin was 28. It was not checked after drainage.
I think is there any other question?
My question is for Dr. Samir. I mean, when they are discussing the role of PET scan, if there is a localized lymph node and we don't know that's enlarged because of infection, inflammation. So do we need to go for a PET scan, or EUS can help us?
If you want to confirm whether or not the lymph node is involved, then yes, EUS FNA would help. However, if the surgeons would say that no, this lymph node would come out and the patient could have adjuvant therapy afterwards, then I think it may or may not be necessary. In our institute, we don't necessarily do PET scans for cholangiocarcinomas for the reason that they're not always positive anyway. We would do, and then if there isn't any obvious metastasis and the surgeons are happy to go in, they would go in.
The corroborative answer comes from the fact that you don't see PET scan in the MUSE protocol, or you see the role of EUS in assessing the lymph nodes, not there is no role of PET scan there as well.
That was too old, actually.
I
No, but
mean,
still,
if the lymph node can be biopsied through if the number one, the lymph node as a starting point is suspicious on a CT scan, and it is accessible through an EUS biopsy, then yes, you can do that. But most of the time, these lymph nodes are a little away, and the endoscopists think that they cannot biopsy that. So just doing an EUS, looking at the morphology of the lymph node and on an EUS, will that add any value?
but the problem is that these patients, they are more often than not infected, and infection will also give you a high SUV and the PET scan as well. That is why I mentioned in my presentation that it is one of the controversies in the literature, and no one knows the real answer.
I think I'll just clarify 2 points. Number one is that we are talking about Hilar cholangiocarcinoma. So in the Hilar cholangiocarcinoma, the PET scan sensitivity and specificity is actually less than intrahepatic cholangiocarcinoma. It's about 60% as compared to 90%, number one. Number two is if you only look at the morphological characteristics on EUS, that's going to be 70% accurate if you look at the rounded lymph node, size of the lymph node and the appearance. But still you would need a biopsy. And if you have, you can actually biopsy them. And in fact, if it is not in the intrapancreatic portion, you always biopsy the lymph node, not the tumor actually. So I think if you have a high SUV values, and if they're very high, they're likely to be malignant. It's inflammatory, they're not very high. But if they're borderline, then probably going in and doing an EUS biopsy would help if you're thinking of a resection.
A mandatory thing going for surgery. I mean, if you look at the PET data based on the pancreatic biliary cancers, PET is actually poor to detect the abdominal lymph node metastasis as compared to the mediastinal and the supraclavicular lymph node metastasis. So if you have a little bit of a suspicion on these nodes, PET is actually a better investigation as compared to the abdominal lymph nodes. Okay, time is up.
Thank you very much. Nice to see you, Dr. Ramzan. It's a pleasure. We have actually worked together. We'll conclude this session. It was a very nice and interactive session. Lots of questions still remain unanswered. I think once we meet again, we'll try and answer those. And thank you very much for all the kind of presenters, all brilliant talks. Thank you very much.
Thank you, Dr. Ahmed. The time is for next session. To introduce myself, I'm Dr. Mohammed Ramzan. I'm intervention radiologist and will be working here in PKLI from now onward. If the people, I think there are many faces, they don't know me. So the next session is a palliative care in Hilar cholangiocarcinoma. There are 4 talks, and they are really interesting talks actually. So first I will invite Dr. Atif Rana to chair the session. Dr. Atif Rana is a known interventional radiologist and he is head of the department in Shifa International Hospital. And he is doing really a great job over there. The next is Dr. Harry. Dr. Harry Kletsidis, please come on the stage and chair the meeting, please. Thank you very much. The first talk is by Richard Sturges. He is trained in UK and he will talk on endoscopic management of Hilar cholangiocarcinoma. He is head of the department at Liverpool University and his interest is in hepatobiliary medicine and he has endoscopy. He has trained many people and he has really rich experience. He will be joining us on Zoom actually And are we on?
Hello, can you hear me all right?
Harry, can you hear me?
Yeah, I can hear you. Can you hear me?
Yes, yes.
Good. Shall I start then? Okay. Well, thank you very much for asking me to contribute to this great meeting, and I'm sorry I can't be with you in person. Although the title of the talk is the endoscopic management of Hilar cholangiocarcinoma, given the wealth of experience and breadth of other talks, I'm going to concentrate on ERCP and drainage of this, what remains a fairly miserable disease, certainly to have, and we are making progress on it, and I think we should be keep that in mind as we talk through now. So if I could take you back a little bit to my youth, when I was about 20 years old. This is the cricket team of the Middlesex Hospital Medical School, and that's me on the right there, or on the left as you look at it. We always used to play the consultants. I'm not showing this just to remind how little I've changed in 43 years, but to show you the consultants team, because playing in that side was this gentleman, who these days looks a bit more like that. That's Peter Cotton. And Peter Cotton was a consultant at the Middlesex when I was a medical student there. And he was hugely influential at that time in British gastroenterology, in world gastroenterology. But the reason I'm showing is because he was really one of the first champions of digestive disease as a group of individual specialties that come together for the management of specific diseases. And cholangiocarcinoma is a prototypical example of the disease where you need genuine multidisciplinary expertise. I just wanted to emphasize that point. So ERCP in cholangiocarcinoma, Hilar cholangiocarcinoma, remains the dominant tool that we use in managing that. I know that's a slightly controversial thing to say, but for most patients, we will be utilizing ERCP at some stage, both for delineating the disease, mapping it out. I'm sure you've already heard about some of the more useful diagnostic modalities, including cholangioscopy and spyglass in enhancing our diagnostic rates. And sadly, for a majority of patients, curative treatment will not be possible, and biliary drainage becomes very important in the palliative management. So just to set us off a little bit, most patients, as I've said, with cholangiocarcinoma will not be treated with curative intent. The resection rates remain relatively low. I think reality 25 to 30%. Most patients will have a resection, so the majority will not have a surgical intervention. However, at presentation, widespread metastatic disease is relatively unusual. It's a lot of patients will present with relatively localized disease. And the majority of patients, again, don't die from widespread metastatic disease. They die from the results of biliary obstruction and repeated septic episodes. And non-surgical intervention for the majority consists of drainage together with chemotherapy. And obviously, radiotherapy is beginning to be utilized more, and there's other niche therapies. But for the bulk of patients, we're talking about drainage and chemotherapy. And this is to a degree controversial, but certainly in our UK practice, the majority of patients on a surgical pathway will require preoperative drainage. The reality is most patients will spend 4 to 6 weeks being worked up for surgery, recovering from a jaundiced episode, nutritional assessment, anesthetic assessment, cardiorespiratory assessments, and if we're going to consider neoadjuvant therapy, the patients will certainly require drainage. And the management of the bile ducts becomes fundamental to outcome. And I'll say this: it's the biliary drainage is the single most important therapeutic intervention for the majority of patients with Hilar cholangiocarcinoma. This is a quote from the seminal paper in the New England Journal of Medicine, the ABC02 trial. And Juan Valle, who's an oncologist in Manchester, and was the first author on that paper, wrote that the maintenance of biliary drainage is critical because it enables systemic chemotherapy to continue without major delay for stent change and avoids potentially life-threatening biliary sepsis. And that sums it up. And you could apply the same statement really to the management of patients coming through for surgery. So one of the most useful things that I've championed during my time as a consultant in the northwest of England was within the MCCN, stands for Merseyside, which is Liverpool and its surrounding counties, and Cheshire Cancer Network. And what we effectively said was that if you've got a proximal biliary obstruction, do not attempt any form of biliary intervention without contacting the specialist hepatobiliary team. And the effect of that is, it means that in the liver unit at Aintree in Liverpool, we receive these patients from across the region without intervention. And it is so important when you are working up a patient with Hilar cholangiocarcinoma that when you intervene with knowledge and expertise and a clear plan. And this, to a degree, has driven out some of the poorer practice that you will still come across in clinical care. So what about the biliary anatomy and drainage? If you are an active interventionalist, and that would be a radiologist, an endoscopist, a surgeon, it is critical to the management, clearly. This is self-evident, we don't need to overemphasize it, to the management of cholangiocarcinoma. But it is complicated. There is significant anatomical variation. There are clearly pathological effects on liver volume, such that one side may become atrophied and the other side hypertrophied. And I'll come back to this one on a short comment about bilateral or unilateral stenting. And clearly drainage needs to be matched to a resection plan. Everyone will be familiar with the sectoral anatomy. I apologize for putting that in, but it is useful to remind gastroenterologists that the sectoral anatomy is of fundamental importance. But, and this slide is just to emphasize the enormous variation that you see in Hilar ductal anatomy. The so-called normal, I don't think anything's normal here, it is just what it is. But it does emphasize that the majority of variation that you see isn't around the right duct. And the left duct usually, but not always, has a good couple of centimeters of clear unbranching duct that can be very useful, as I'll come back to. Here's an example of variation in biliary anatomy. This is a patient. It looks like a slightly complicated hilar, and you can't quite see what's going on with the wire. This is just in a straightforward PA projection. If we then just spin the screening head a little bit, you can quite clearly see that the right posterior sectoral duct is coming off from the left main duct, which is a relatively common variant that we see and can be used to advantage because a single unilateral stent into the left, if there's a Hilar block to the right, or a block to the right, stent on the left, unilateral stent, mind you, will drain at least 2/3 of the liver. It'll drain all of the left and all of the right. So we'll come back again. We'll come back to the unilateral, bilateral business shortly. But the understanding of biliary anatomy and I'm talking now about the non-surgical gastroenterologist whose knowledge of anatomy will certainly be less developed than his surgical counterpart. The knowledge of this aspect of intervention is critical. So what about the tools that we use? Plastic stents have been around from Peter Cotton's day, and they remain very useful and applicable in the drainage of hilar cholangiocarcinoma. And we will use both a pigtail for temporary, very temporary drainage, or straight stents where appropriate. But what has changed the game a little bit, and it's not a recent development at all, is the self-expanding metal stent and its ability to be delivered on a slim catheter and then expand to very significant diameters. And this has certainly changed the game in a whole variety of settings, including coronary arteries, luminal gastroenterology, and particularly in biliary gastroenterology. So what are our aims when we're draining a cholangiocarcinoma? Clearly relief of jaundice, so the bilirubin coming down, but that, without being somewhat pejorative, anyone can place a stent to bring the bilirubin down. It's the avoidance of sepsis, so not a pacifying undrained segments where it can be avoided. The acquisition of tissue, effectively now without a pathology report saying carcinoma on it, you will not get a resection or chemotherapy, certainly in the UK. And critically, the drainage of the appropriate sectors to support planned surgery. There's absolutely no point draining the bit of liver that's going to end up in the pathology pot. For enhanced survival of the non-resection patient, it's drainage that optimizes repeated future interventions, because even with metal stents, they are going to block. And if you're going to get patients to survive, to get them out to 2 and 3 years for that small group of patients who will go there, you will guarantee that one can guarantee that you're going to have to go back and redrain segments. And if your initial placement of a stent was injudicious, shall I say, that drainage then becomes much more difficult at repeated intervention. And it is worthwhile spending a week or two, if necessary, to get absolutely optimized drainage, be that with ERCP or a combination of ERCP, percutaneous, or EUS guided approaches to optimize that drainage in a patient where you are looking to get significant survival. The initial intervention has a major influence on outcome. There's no doubt your best chance of getting it right is the first time you do it. We do see some suboptimal practice, but as I said earlier, I think that is beginning to disappear, certainly in our own area, with greater knowledge and better organization of care. And the lack of tissue sampling and lack of rescue when clearly something has not gone well is disastrous for patients, but we see it less and less, I have to say. So what about optimizing? What are we talking about? Well, studying the cross-sectional imaging and I'm talking about the endoscopist now, and have a clear plan of what you're going to drain, and that often means consulting with your surgical colleagues through a tumor board, multidisciplinary team meeting. We drain, as I said, we do not drain atrophic segments, we do drain the future remnant. You need to drain an adequate volume of liver, and you don't want to waste it by the unnecessarily proximal placement of stents that then subsequently block side branches. And really, you need to be draining 2/3 of a normal liver to get effective and long-term drainage. But as I've mentioned earlier, it can be difficult to interpret and requires some thought to get that right. And I would suggest that if you've got a patient who doesn't have widespread disease, an aggressive approach that utilizes both PTC and EUS guided drainage may be required. And I would advocate the use of metal stents where it is appropriate, and I'll come back to that in a second, and the precise placement of those stents. So what do I mean about precise placement of stents? So here we see a fairly, it's quite old slide now, fairly straightforward hilar cholangiocarcinoma with separated systems. And these stents have been placed, they're clearly across the stricture. They've gone a reasonable distance, so they're not likely to migrate, but neither have they been placed very deeply into the liver, blocking side branches. They're shotgunned out at the bottom so that we can get endoscopic access to both sectors for repeated intervention. So precision placement of stents, a wide stent across the stricture that's stable, so that for most cases will be a metal stent if you can, uncovered or covered as appropriate, and the left lobe or the left duct is often you're often able to place a covered stent without blocking significant side branches. As I said, minimal occlusion of side branches and easy repeatable access, which I call, or what we call, shotgun stents. What about plastic stents? It's not a lot of patients will be drained with a plastic stent, at least 10 French. 7 French stents just won't stay open, as everyone knows. It's the variation or the complexity of the right ductular anatomy that often makes it difficult to place a metal stent. If we try to place a metal stent here, we would end up that metal stent going out one of these branches, but not draining the others. And the combination of a plastic stent to the right and a metal to the left, you can be a little bit imaginative about how you place those. There are, as I say, there are options. This is actually a lymphoma case. And I wanted to get a metal stent in here so we could drain both. But if we tried to use a metal stent into either of these any of these branches, it would have occluded the other side. So what we've done is put a metal stent just through the stricture, but then used pigtail stents into either branch just to hold that metal stent open and allow drainage from both sectors whilst it expands across in this case, a very treatable malignancy. So the question of unilateral or bilateral. Well, I don't think this is the right question. It should be, and although this is somewhat simplistic, it should be the volume drained. And it's the variation in anatomy, the pathology that's applied in terms of whether it causes any hypertrophy or atrophy, that means that, as I explained earlier, a unilateral stent can drain an awful lot of liver. But sometimes you will require bilateral stents to get an appropriate drainage. So the question should, as I say, should be the volume drained rather than unilateral or bilateral stents. And the other question is the surgical remnant drain? And I keep coming back to that because it's obviously clearly critical for preoperative drainage. So this was just some data we didn't publish, but it's an audit data from our own unit some years ago now, looking at our patients. And I just want to focus on this slide. It shows you this is just simply survival. As we go out, and clearly you're going to lose a lot of patients in 3 months or so who have got widespread multi-stricturing disease where you never actually adequately get them drained. And then there's a group of patients, and then it steadily falls off. But there are significant numbers of patients, 10 to 20%, 15%, who will go 18 months to 2 years with and will require repeated drainage and benefit from the oncological input. And you could look at this slide and say, well, there's no difference between unilateral or bilateral. What's the point of trying to place bilateral stents? That would be absolutely the wrong takeoff from this data, because our practice would be to drain an adequate amount of liver. Often that can be achieved with unilateral stenting, but sometimes you do require bilateral stenting to get that drainage. And in those patients, unilateral stenting would have been inadequate without a doubt. So this reflects our practice of draining by volume rather than deciding, say, we always place bilateral stents or we only ever place unilateral stents. You should place stents to drain enough liver, and that data reflects that practice. What about preoperative drainage in hilar cholangiocarcinoma? And I appreciate this is controversial area, but as I say, our UK practice is predominantly to drain prior to surgery. So, and again, another hilar cholangiocarcinoma. I've shown this slide of us taking biopsies and brushings as well, because having a positive positive histological diagnosis of malignancy is a critical step in the management of patients, and being aggressive with both brushing or multimodality biopsy, and we could put in a cholangioscope as well at the same time now to get tissue, is a very important step. And then this is what I would call stents that are optimized for preoperative care or a preoperative pathway. We've got, on this case, bilateral stents, but they've been placed very acutely just beyond the stricture. Now, there's a chance that these stents might open up and migrate or slip down, and that's why I wouldn't place stents like this if I knew the patient was going into a palliative setting. I'd place them more deeply, but this type of placement for preoperative drainage allows the relatively easy removal of uncovered stents, all covered, at the time of surgery. And this, Hassan may have mentioned this in his talk, Hassan Malik, my surgical colleague. This was a small study that we published 10 years or so ago, 25 odd patients, showing that patients who had metal stents, they could undergo a resectional surgery without any problems at surgery, but also they actually had a better outcome than the plastic stent, but it was a very small study. We've currently got data which is about to be published it's a multi-center retrospective international cohort study. So it involves ourselves together with European centers at Rotterdam, Amsterdam, and Austria, in Innsbruck. And it is retrospective, and it's comparing the use of metal stents to plastic stents in preoperative drainage. There was a cohort of 471 patients, and 61 had preoperative metal stents. And then this was all matched down, so there was actually a matched cohort of I think it was 57 patients in each group. And the key message coming out of this data was that there was significantly reduced stent failure. And when we start talking about stent failure, we're talking about recurrent jaundice or cholangitis requiring further intervention in patients in the preoperative phase. And bear in mind, we are moving probably to neoadjuvant care, where patients will have prolonged preoperative phase and chemotherapy. And there was no other difference in other complications, and no difference in those undergoing surgery. They had exactly the same outcomes, other than the fact the SEMS group had a significantly lower re-intervention rate. So I'm going to finish there. As I started by saying, it is a miserable disease. Most of our patients will not survive. And I've been, as a consultant, I've been managing it for the last 28 years, I think. And we are making steady incremental gains and improvements in care. So I'll leave you with a picture of the Yorkshire Dales, where I was walking last week. It's beautiful countryside, and we've got a similar sunny day like this today in the United Kingdom as I look out my window of my study. And thank you very much, and I'm happy to take questions now or later. Thank you.
Thank you, Dr. Richard, for delivering a really nice talk, and you can say explaining the anatomy very well and stent placement. Are you staying with us for question answer session, or we can take some more questions?
Yeah, I'm staying on. I might need to disappear for a quick drink, but I'll be here for the session. Yeah.
Okay, that's fine. Thank you very much. Our next talk is by Dr. Anand Sai, who is Professor of Medicine and Chief of Gastroenterology Division in University of Montreal. He is globally recognized, and he has trained like more than 500 people across the globe He had received many awards, and he is going to talk on EUS in cholangiocarcinoma, where does it stand? So, Dr. Anand Sai.
Good morning. Thank you for your very kind invitation. I will try and share my screen now. Hopefully this will work. Desktop 1, PowerPoint. Allow Zoom to share your screen. Oh boy. I'm a little concerned that this was going to happen. I'm just trying to see. I don't know if I sent my slides and because it's not Zoom. Okay, hold on. One sec. Okay, so now is it working? There we go. I believe here we go. Okay, so I'm hoping you can see my slides.
Yes, we can.
Okay, excellent. So thank you again for your very kind invitation. I'm here to discuss the role of EUS in cholangiocarcinoma. And to be honest, I think it's a challenging disease for EUS. I will try to go over some of the unique information you can get from EUS regarding differential diagnosis, diagnostic options, and therapeutic options. I will say that I think you've had some excellent talks on therapeutic options that I think go beyond the scope of this talk, because there's people who are much more expert at that than I am. So I think I'll focus more on the differential and the diagnostic options, and certainly hopefully we can have some discussion after that. So I think it's important to remember that EUS, I think, is here to stay regardless of improvements of cross-sectional imaging, because it combines the ability to have high resolution imaging with tissue acquisition or access via devices now for therapy as well. And despite the fact that, ultrasound and be a fairly old technology, this combination is hard to beat. And even if cross-sectional imaging becomes better and better and can identify small structures, the ability to access them for diagnosis or therapy will always be limited, because going by the percutaneous route obviously is uncomfortable, you have to go through multiple structures, and there's also the risk of tumor seeding. So I think EUS for this type of oncological indication is here to stay. So this is an example, for those of you not familiar, of the probe. Here's a very small 4mm node with a needle inside. So giving you an idea of the type of things that we can sample quite easily, things that often can't even be seen by CT scan. And then our new probes allow us to do Doppler as well, which can help with the vascular staging in many types of cancers. I think what's really revolutionized EUS in the last few years is the new availability of what I call cutting needles. So EUS tissue acquisition was originally cytology, which was not bad, with yields of over 95% for cancer in cases where cancer is present. But what's great now with these cutting needles is that's even better. And so the yield for cancer, I'd say, is almost 100%. And the advantage now is that when it's positive for sure. And you can also get easily enough tissue for genetic analyses. But when it's negative, when it was negative with cytology, you could never be sure if it was a true negative or a false negative, because you're just not getting cancer cells. But what's great with these cutting needles now is that you get true tissue. So you're getting target lesion tissue. And then if there's no cancer, but you have target lesion tissue, it shows you that there really is no cancer. Or in many cases now with pancreatic biopsy, not only is there no cancer, but there's presence of a benign condition with histological confirmation of things such as autoimmune pancreatitis or chronic pancreatitis. So things that you can be confident, one, that there's no cancer, and then often we get a positive diagnosis of a benign condition that can explain the clinical scenario of the patient. And this is the type of tissue we're getting now, just with one or two passes. You can see on a slide here, these are histological cores, and there's so much material here that it's actually hard to do cytology anymore. You have to do a touch prep. And with one or two passes here, we have a huge amount of material here. You can see with no blood that allows us to do genetic analysis. So what we've moved on from getting in-room cytology to using what we call macroscopic on-site evaluation. We're simply putting in the needle, expressing the sample. You can see if you have white tissue, you know that you have tumor material. And several randomized studies now have shown that this is sufficient to completely obviate the need for on-site cytology. I would recommend for those of you doing EUS and these type of biopsies, if you can afford these needles, I think this is really the standard of care now. The problem is they are quite expensive. And when you're sampling these lesions, all these samples here were obtained with no suction. We also don't use a stylet, but if you use suction, you aspirate blood into the needle without increasing the amount of tissue, really, in my opinion. So if you avoid using suction, you get actually these great samples with no blood, which really allows you to do the macroscopic evaluation much better. So you can see clearly whether or not you have tissue. If you have a lot of blood, sometimes you can't tell if it's blood or if it's actually tissue core. So this makes it much easier. And as you know, we can do liver biopsies as well. Same thing in these patients now. Sometimes liver lesions are in question. And this is just a simple one pass with a liver biopsy. You can see a very nice bloodless sample of pure liver. So the other thing about EUS is that, as I say, we can see things that you can't see on CT. This is an old slide of a radioscope in the stomach. And just to show you that these types of small pockets of ascites are things that can be found on EUS and that cannot be seen on CT. And these can certainly change management in patients with cancer. So in patients with cholangiocarcinoma, it's not frequent, but there are cases where we do identify ascites that was unexpected. This can also be sampled. Or certainly stimulate the need to do laparoscopy to make sure there isn't carcinomatosis before going any further. So just keep that in mind. And I would add also that in our center, certainly it's pretty much between standard of care to do an EUS before any surgical attempted surgery for cholangiocarcinoma, because even if there are no nodes on the CT, we can find nodes sometimes that they don't see. And if we biopsy them and they're positive, it really changes management. So as you know, for EUS, we go through the stomach. And just to point out that, you know, we have really good access to everything around the pancreas. Anywhere that's touching the duodenum, we can get very good images of, particularly the vessels here. And when it comes to cholangiocarcinoma, I think it's just important to realize, though, that although we get excellent imaging of the extrahepatic bile duct and lymph nodes, the vessels in the hilum, beyond the bifurcation here is really not a great zone for EUS. And we're talking about hilar cholangiocarcinoma today. So in our practice, certainly, I think we're most useful for identifying signs of distant disease, so nodal disease outside the primary tumor in the hilum here. But when we're talking about purely Klatskin type lesions that are really just intrahepatic, we actually don't get great imaging of a mass structure in this area. It's quite surprising to me, but honestly, even patients with obvious malignancy, we are not very good if there are no nodes in identifying actually the primary disease. And in our experience, just blindly biopsying into the hilum has not been very successful in terms of getting a tissue diagnosis. But certainly for everything around the hilum and looking at the vascular involvement in the hilum, EUS can be, I think, really offers a unique approach to this area of the body. So just for the differential diagnosis, obviously for distal stricture, just remember the primary diagnosis is primary pancreatic cancer. The difference usually with pancreatic cancer is that there's pancreatic duct obstruction, although you can get pancreatic cancers, for example, in the Uncinate process that do not touch the pancreatic duct. But to distinguish a small pancreatic cancer that's involving just the bile duct versus a primary cholangio, I think is basically impossible unless there's some type of tumor marker that can help that. But in the end, I don't think it really affects management. I would just say, if you do have CT negative jaundice, and there is question of a small biliary, a small distal cholangiocarcinoma or a small pancreatic adenocarcinoma, if at all possible, do the EUS before you do an ERCP. Because if it's a small stricture and then you put in a stent, particularly a metal stent, it can be basically impossible to identify a small distal cholangiocarcinoma. And we find this quite a lot. I would, if you do need to stent somebody, at least until you have a tissue diagnosis, please put in only a plastic stent so that at least it's a little easier to identify small distal cholangiocarcinomas, and we can still biopsy. In some cases, if you have put in a metal stent and there is a small distal lesion, we can still biopsy through the metal stent, even though we don't really see the primary lesion. And there is some success in doing this, but it's definitely easier for small lesions to get the diagnosis if there's no stent or at least only a plastic stent. For hilar obstruction, I find there's many diseases in the hilum, both inflammatory and malignant, that are very hard to diagnose. These include Moritzi syndrome, gallbladder cancer, nodal obstruction from other metastatic processes is actually not that hard to diagnose, and then autoimmune cholangiopathy. So Moritzi syndrome, looks like cholecystitis, and both Moritzi's and gallbladder cancers I find are very hard to distinguish. What you see in both generally is that they all have at least one huge stone, usually more than 2 centimeters. And in Moritzi's, when you see the hilar stricture, when you turn away from the stricture, you see immediately this huge stone. The problem is you have a lot of inflammatory changes in the gallbladder wall in that area. And then to distinguish those from gallbladder cancer can be quite challenging. And then biopsying to diagnose here is also challenging because we're always a little bit scared of biopsying into, not clearly mass lesions in the gallbladder due to the risk of gallbladder leaks. But if you do find a large mass component, I think it is quite safe to biopsy to the gallbladder. If you can get a window through some normal liver, I think that's safer as well. Nodal obstruction is not a major problem. In these cases, you will really see that the bile duct is obstructed, but you can clearly see these nodes in the hilum obstructing, and often these patients have a history of some other primary cancer already. And as I say, with the new cutting needles, and even with cytology, you get a tissue diagnosis quite easily. Autoimmune cholangiopathy, certainly the type that's associated with pancreatic lesions, can produce a typical sausage appearance or focal mass lesion in the pancreas. The difference is that if there is pancreatic duct obstruction, it's less of a malignant apparent obstruction. It's more of a partial obstruction with not as huge pancreatic duct dilation. And again, here, the cutting needle biopsies, in our experience, have been quite effective at diagnosing this and excluding pancreatic cancer or cholangiocarcinoma. So diagnostic options, again, in these hilar strictures, if you do see a stricture in the hilum of the primary lesion, so not intrahepatic, but in the primary lesion, we are able to take biopsies, but our surgeons tell us not to do the primary lesion because there is a risk of tumor seeding and it becomes a contraindication to liver transplant. So in those cases, we really try to focus on any nodes that we may find. I do find it interesting that in cholangiocarcinoma, as compared to pancreatic cancer, many of the more even benign looking nodes in cholangiocarcinoma can be positive when you biopsy them, whereas even the most suspicious looking nodes in pancreatic cancer often are negative. And it's important to remember that if anybody's had an ERCP, just doing a diagnostic ERCP produces lymph nodes immediately, and quite large lymph nodes often. They look fairly benign. So just don't be surprised if you see large lymph nodes in somebody who's had an ERCP. In most of the time, certainly in pancreatic cancer, those are just inflammatory benign nodes. You can biopsy them if they'll change management for you, but don't be surprised if it's negative. But in cholangio, if you see small nodes, I think it's worth sampling as many nodes as you can find because you get some surprises of a positive diagnosis in fairly benign looking flat, for example, lymph nodes. As I say, hilar biopsy, if there's no nodes accessible and you just want to try and biopsy into the hilum, we've done it. I think in the years, we've probably had one case where it was positive. And I looked a bit in the literature. I couldn't really find a lot of literature on this, but you can try it, but don't be surprised if it's negative, even in an obvious Klatskin tumor with strictures in the hilum. But I guess it's worth a shot. Be careful. There are vessels around there and you can get bleeding. In some patients, obviously, with hilar cholangio, there are separate metastatic liver lesions. And if you can find those can be easily biopsied with extremely high sensitivity for cancer. And that's, I would say, maybe 25% of the cases of hilar cholangio, we find metastatic liver lesions that we can biopsy. Finally, the nodes, as I say, are our primary workhorse for getting a diagnosis in cholangio. And if there's any nodes available, certainly try and biopsy those. So moving on to therapy, as I say, I think you've had already some excellent talks on therapy from people that have a lot more expertise than we do. For distal obstruction, as you know, you can do rendezvous procedures by EUS to put a wire through the papilla and allow primary ERCP. And then the new kid on the block is choledochoduodenostomy using lumen-opposing metal stents or standard metal stents. And just to say that this procedure is really very, very easy. We're getting more and more data now on the effectiveness of these stents as compared to ERCP. And my feeling is that for patients who come from malignant distal obstruction, who need an EUS for diagnosis and staging, it'll be cost effective to do an EUS drainage immediately, as opposed to sending them then on to ERCP. There's just to show you the major concern, I think, was that the lumen opposing metal stents that we put in at EUS may have a different stent patency compared to standard EUS ERCP stents. And just this recent randomized trial showed that that's not the case, that the 1 year stent patency is basically the same. The difference is that if you take all comers with jaundice and you randomize them to ERCP versus EUS, the success rate for ERCP is lower than they expected, even in this expert center, with about 25% failure due to duodenal involvement, which is not an issue for EUS. So the technical success for EUS was quite high compared to ERCP. So just to say that for distal obstruction, I think watch out people who do ERCP. I think EUS may become the primary intervention in these patients, since it allows one-stop shop for diagnosis, staging, drainage, and then even gastrojejunostomy if necessary. And then obviously for failed primary ERCP drainage, EUS does offer the option of either anterograde stenting by puncturing the liver and passing a wire down through the papilla, or hepatogastrostomy, which despite I think fairly still high morbidity in these patients, is probably the only option, and it's definitely a reasonable option at this point. We've had improvements in stent design that reduce leakage. I think there will also be soon a hot delivery system like the Cholangiocarcinoma, the Axio system that allows hepatogastrostomy. The current problem is that the delivery system needs to be introduced deeply with the hot Axio system to allow deployment of the stent. But I think if they produce a system that allows safer, less awkward, what we call forward deployment of the stent, where you put the catheter into the system and simply push out the stent into the bile duct, then you wouldn't need as much room here, and you could just deploy a lumen opposing metal stent here, in between here and here, without the need necessarily even for fluoroscopy or wires. So I think that will be coming up in the future. So there may be some space for EUS, more space for EUS in hepaticogastrostomy. And then in failed distal obstruction, if there is no access to the bile duct, we can do palliative gallbladder drainage as well. It's quite simple as long as the cystic duct is permanent. But obviously in a hilar cholangiocarcinoma, this is not really a consideration since the obstruction is above the cystic duct usually. So this is just to mention that this is possible in distal obstruction. So in summary, I think the take homes here, EUS provides unique access to high resolution imaging combined with high yield tissue acquisition that provides both a diagnosis of cancer and can confidently diagnose, I think, benign conditions that can mimic cholangiocarcinoma. In terms of diagnosis, the primary role is in nodal sampling or really distant liver lesions. But actually primary biopsy of Hilar Klatskin is quite ineffective, certainly in our experience. And in terms of therapy, I think the primary value is an hepatogastrostomy or allowing a rendezvous procedure by passage of wires. And with that, I thank you for your kind attention. And this is a picture of Montreal. The snow has melted. Don't worry, it's actually quite nice outside. And we do have an EUS meeting coming up in September in Montreal, and we'll be sending out info on that. And hopefully some of you can make it to see Montreal if you've never been. Thank you again for your attention.
Professor Said. Thank you very much, Professor Said. It was really an amazing talk, and really you're using. Are you listening?
Yes, yes, yes.
Yeah. So are you staying with us for
yes, for sure.
Question answer session? Thank you very much. We'll move to the next talk is by Dr. Najmuddin. He is known to everybody. I think I don't need to introduce him. He is the pioneer of IR, and the talk is about percutaneous biliary drainage. Thank you, Dr.
Thank you. Thank you. Thank you. Being at the end of the session, in fact of the day, it makes my life easy because I'll skip quite a lot of slides. Most of the things overlap with the GI and endoscopy people. So I will go through them much more quickly. And you can then go home. But the most important person is coming after me, the palliative care person. This disease needs a palliative care person more than anybody else. Anyway, let's kick off. I was amazed to read this figure that Global Cancer Observatory report for 2020 noted that in Pakistan, we had about 5,000 plus new cases of gallbladder carcinoma and related disease. But look at the figures up there. They're pretty dismal. 41,000 expected in 2023. Half of them practically will die from this intrahepatic bile duct cancer. Gallbladder cancer, we think does better, but again, 1/3 nearly die from it at the end of the year. This is sure thing. It would have been better if I was sitting somewhere else and I was online. It works better, does it? Thank you, Ramzan. So there is a bit of optimism hinted by. We don't have our figures. In fact, I thought we probably will eventually have some figures for Pakistan, but I'm very certain this figure is very small, considering the volume of patients we see for gallbladder disease. You've seen this so many times now. I'm sure you're tired and sick of this color and this slide, but this sets up my basis for the next thing. As a radiologist, this is much more interesting to look at. Is the tumor big enough, like a solid blob, or is it going along the mucosa? Is it really on one side of the wall or the other? All these things for an imager, for imaging guy, becomes much more practical when we are applying our intervention into it. So if I was to consider actual TNM and classification, we all disregard it when we are talking about biliary cancer. We simply take bismuth or the other parameters, surgical parameters for staging. But for me, per se, I would be more interested in knowing T2, T2A, and T2B disease. And that's the catch for most of the decision making for surgical patients as well. It helps me design my thought process and talk in the MDT setting as to how I will proceed. Should I stay back from this patient, or should I proceed with percutaneous transhepatic biliary drainage? Or maybe my GI endoscopist would do a better job. Anyway, so if you look at these images, smooth luminal narrowing with a patency, still appreciable, tells me that I can probably, this can go either way. An endoscopist can do a better job, and I can also take a quick go at it. But when it comes to a lesion where you have an irregular asymmetric structure like this, in which the direction of the nipple of the lumen is going in, not in line with the distal CVD, which is still visible, then it becomes a bit tricky. And on top of that, if you have something which has got a large polyp sitting on the side, if we can appreciate a lumen on the right-hand side of this polyp, this also becomes a procedure which we can both address when we are making choices between endoscopy and percutaneous intervention. So when we do cholangioscopy, most of the time we end up seeing all these parameters, and we tend to decide upfront whether it will be easy for us. First gut feeling we get is that I think it'll be a two-set procedure. I won't be able to do it in one go and probably do it in two settings. And then again, when we are looking at the entire cholangiograms and MRCPs, we hardly ever get an idea until unless we come up to the cross-sectional imaging part of the entire investigation which has been done as to where exactly the tumor is sitting. So we are not really clear as to what is the anatomy of vascular anatomy or the otal anatomy around the lesion. And then obviously this is much more relevant when it comes to staging for surgical decision making. But CT gives us a better idea. So it's essential that before we proceed with our intervention, we have a good view across the lesion to actually determine whether the extent of invasion, how far it is beyond the actual lumen which we are looking at. And obviously it becomes much more relevant when you are talking of surgical staging, preoperative staging, whether it's Blumgard or his colleague Janending. The stages are totally different. I was surprised that there was not mention of biliary drainage in the NCCN guidelines. Quite a lot of oncologists actually follow these or their own guidelines, but they're only using the words consider, they're using the words if indicated. And when you go into the details, there's not much of a mention as to how it should be done. So we are actually limited to data from our own societies with which we can make decisions on. The Asia Pacific, I'm sure this has been also shared with you, but they are tilting more towards PTBD as the upfront modality for decompression. And in combination, it can be used in combination with endoscopy rather than alone in a number of cases. And that's what I'm saying, that if you were to decide upfront on imaging, who will take the first charge at the patient? That's very important to decide in the MDT. This is the algorithm followed by the Asia Pacific, won't go into details, but ESGE has clearly said recommends against routine preoperative biliary drainage, and preoperative biliary drainage should be reserved for, obviously, as mentioned earlier by my colleagues, only for symptomatic patients. And the use of 10 millimeter stent is now definite. There's no argument about it. I don't see any stents being sold for this procedure less than 10 millimeters. It also talks about SEMS for insertion. So that's the support that we can use a SEM insertion for palliative drainage purposes. And then it also supports not using covered stents for unconfirmed etiologies. So, I don't know, majority of our patients, we do not require histologic examination, but still, if that's the case, we do not have a definitive diagnosis, then uncovered stents should be awarded in these patients. So it also suggests against routine preoperative biliary drainage. We've already dwelled on it, recommend uncovered SEMS for palliative drainage of Hilar. So these are the guidelines. These are the recommendations from the ESGE guidelines. The algorithm which I liked was very simple. Before surgery, ERCP, fine. If that is possible, do it. If you can avoid cholangitis in these patients. But for palliative, obviously PTB remains mainstay for percutaneous stenting. We still have patchy data, and obviously local expertise makes a huge difference as to what you will rely on eventually. So it can be curative or palliative. Curative intent, as already highlighted by everybody, the jury is still out, and biliary obstruction is associated with an increased risk of liver failure and cholangitis. That's the only key or empiric argument on which you can base preoperative decompression. And in order to avoid atrophy as well of the FLR. So best options for preoperative Claskin systematic review and meta-analysis all favored that if you do it, then between the two modalities, cholangitis, pancreatitis, and hemorrhage, there was not much of a difference, but there was a slight tilt towards PTBD as a pre-runner. One thing which I have not seen much, but possibly it's being taken up, is the use of endonasal biliary drainage as a possible decompressive methodology in these patients. And in this, you can appreciate that despite the shift, the endonasal biliary drainage did slightly better. The type of drainage predicts short-term outcomes. Obviously relying on the data set, the incidence of major post-operative morbidity becomes the denominator, and PTBD does relatively better than endoscopic procedures. Another multicentral trial, which I've been told has already been shared. This puts off us as radiologists quite so worse, because this was closed because of 11 deaths up front through PTBD. And I'm not sure, we've been arguing on it since yesterday as to why would somebody have such a large number of deaths, 41% deaths up front. And this was a Dutch Cancer Foundation supported study. So anyway, the clinical goal is to ameliorate clinical symptoms and improve quality of life and possibly survival. And the objective here is, as has been highlighted, the decompression of more than 50% of the total liver volume is the bottom line. That's the key for all practical purposes. 3 and 4 are rather big challenges, more so stage 4, because they are all isolated. And in order to get up more than 50% of TLV as a baseline, it becomes really a challenge. Should we actually attempt it if the disease is beyond second order biliary tracts, and we cannot really in the long run offer these patients? And that's where probably, and depending on how late the patient presents, the challenge comes for the end of life counseling in these patients. So if a single stent cannot drain more than 50% of the TLV, multiple drainages would then be justified. Interesting paper, 72 patients were included in this study, and what they did was to assess 50% or less cutoff points by using three-dimensional assessment of the hepatic volume. And they claimed that they were much more precise in defining whether the volume estimate was better than standard 2D eyeballing probability. But the thing which was highlighted was that, and this has actually come out, I think, fairly recently in February 2023, that they had shown definite survival benefit with more than 50% drainage. And same was true for the overall disease process with the effective drainage. That was, as showed in our case, which we discussed, if you reduce the overall bilirubin by more than 50% or less than 3 milligram per DL, then that would be labeled as effective drainage. So that will make a difference in the overall survival. And even if you added chemotherapy or chemo treatment, then that would affect your subject to more than 50% decompression, which will add to your survival benefit. But nothing else made a difference. All other changes, age, gender, KPS, and bismuth type, biliary tumor, child status, unilateral or bilateral stenting, and median pre-procedure bilirubin, all were, they had no statistical differences or add-ons. I'm sure this has been dwelled upon quite a lot, differences between PTB. I think we all have a lot of experiences. Those centers who primarily do PTBD would obviously highlight that it's well tolerated, and it's a higher technical, it requires less technical skills. Well, same stands true for ERCP. What modalities do we have? External biliary drainage, internal biliary drainage, and percutaneous SEMS placement. I think I, for one, am totally against just doing only external biliary drainage in my patients, and I could not find any support for it either. Endoscopic versus percutaneous biliary drainages. Again, the support for this in this meta-analysis came out with a odds ratio of 2.53 in support of PTBD, but there was no difference in the overall adverse effects and 30-day mortality in this analysis. More time, and it costs more in the end. Diameters, I've already mentioned, 10 millimeters and above, and then pushability is much more better with all the type of SEMS and material which we are now facing. The long pushable plastic stents obviously are difficult to handle. Patency time is now more than 10 for bilateral disease and covered stents. It does not occlude the side branches, partially covers the stents. And stent occlusion by tumor ingrowth and overgrowth occurs up to about 50% of the patients, and removing these stents become an issue. And this also happens, the malfunction in the covered stents because of the biofilm formation and sludge and calculi related to that event. So percutaneous treatment of malignant jaundice due to covered, that is viable, and then viable and versus uncovered stents. 60 patient accrued 1-to-1 runoff randomization. Then stent dysfunction occurred obviously more in the uncovered stents. The longest time with the covered stent was 179 days. Tumor overgrowth, ingrowth was obviously exclusively with the Bayer stents, but the complications and mean cost were similar in the two groups. Another meta-analysis with 5 multicenters RCTs, were large number of 781 patients, showed that there was really the uncovered stents did better for palliation. Stent patency was longer, and the patient also survived longer. But stent migration, tumor overgrowth, and sludge formation was a problem in the covered stents. So we can have both types, unilateral and bilateral, depending, again, as I said, what volume you have handled. And there is not much of a difference. I'll move on quickly to show you this last meta-analysis in which a randomized controlled trial did eventually show that bilateral stenting had some edge over unilateral stenting, but otherwise majority of this is a endoscopically done assessment, and then the percutaneous retrospective trials. All of them did not show much of a difference between the two, unless you were using this. Then I evaluated the stent by stent and stent in stent placement technology or methodology. And again, this was not really a very, they did not show much of a difference. I'll skip the 2019 and 2021 meta-analysis and come to the most recent one, which is 2022 meta-analysis, which had 5 comparative studies to 50 patients, 20 single-arm studies, and they showed bilateral cyst deployment has a higher technical feasibility, but SBS somehow had a longer patency rate in this meta-analysis. So now we have a large open cell type of stents, and at least for radiology, and small closed cell stents. Majority of us would end up putting up small wall stents if we can get 50% of our volume drained. I'm not sure how biodegradable stents would behave in Hilar cholangiocarcinomas. And that's what happens with the large moving cell stent that you would have if when you're placing it in. It's a 4 millimeter cell. You can dilate it up to 10 millimeters easily, even with this dilator. So radiologist needs to show some images. I'll just go through these quickly, showing you bilateral internal external stent placements. And our preference is basically to put a stent first in from the right side, and then tap the next stent in, and then balloon, dilate, and make our Y stents in majority of these situations, giving us such a figure. Re-intervention in recurrent biliary obstruction remains something which I could not get any information on, much information on. There's a lot of difference of opinion, but it occurs in about up to 45% of patients, and no definite evidence of effective re-intervention data I could not find any. Plastic stents or covered stents can be exchanged easily. We know that And bilateral stems becomes much more challenging when you are replacing or opening them up. The number of stents types or stent configurations and level of stent position makes a huge difference in making a selection again. And it's all very controversial. So it basically is a choice of the interventionist as to what to do. We end up placing in majority of patients a internal external stent in the blocked systems. RFA has already been addressed and I won't go into it, but this is interesting and we've not touched it. We're not doing it over here. And sitting at the back, we're thinking what kind of equipment which we will use, kind of improvise to do this in our patients. But will it really make much of a difference in gaining 3 months with the cost involved with it? I'm not sure. That's something which we need to discuss in our MDT meetings to decide on. But given that, I'm sure Harry has already shown this, so I'll skip it, but it does make a huge difference. Same stands true for the combined simultaneous 1 to 5 iodine seed stranding. And the majority of the data coming out from Chinese is just amazing that they are challenging what RFA data is showing. And this is how they determine how much of radiation has been given. And they've shown both progression-free and overall survival differences and the improvements in these patient subsets, even with metastases and without metastases. So I'll jump that, but it has shown a difference in survival overall. These are the things which have already been addressed, but they look all very nice going from the left side. And I think that's something which will probably make a difference in quite a number of patients in which we have blocked systems. Everything is chalked off, and then we end up having intrahepatic biliary dilatations. How to communicate right and left lobe into the stomach and or duodenum would be the next challenge. Percutaneous cholangiography and scopy both can help us in defining our pathway in through the difficult cases, and obviously taking samples as we go down, something which we are not used to. We've only used the urology equipment for this purpose, and it seems very exciting, but something which we can take on in our clinical practice. But majority of our patients are at a very late stage when they arrive in our system, and the question remains stent or not to stent. And I think this is something which probably our next speaker will address as well. There's not much literature. It's interesting. Look at the names of the authors. They're all from the top US centers. They could not find any literature either. And that's what they've written the paper on. Then, they applied the evidence and looked for all kinds of papers. There are case series, and then there are a lot of repetition in these case series. So it's abysmal. But again, their conclusion I don't agree with. They concluded that the limited evidence does not support the benefit of palliative biliary stents in this population, outweighing risk. So the challenge was in re-intervention cases, patients who have ECOG 4 or ECOG 3 kind of things. That's a totally different story, where you can't really put it down to the same level. So they proposed that the end-of-life care should be discussed first, and then an interventionalist should come into action. And I quite agree with that. In fact, that's the proposal which I agree with that. Cost, it's very interesting. Another critical aspect which was a surprise to me. Yeah, I'm off. Thank you. Conclusion. You're so right. Thank you very much. But the key here is more than 50% decompression. If you can't do it, then don't do it.
Thank you very much, Dr. Najam. Really good experience you shared with us. The next talk is by Dr. Haroon Hafiz. Is the talk about end-of-life care. He is trained in UK and has really extensive experience in palliative care. He is currently working in Shaukat Khanum. Thank you.
Assalamu alaikum, everybody. And first and foremost, thank you very much for inviting me to speak here on end of life care. And it seems like it's probably the last talk of the day and the conference, which should go in line with the management strategy for these cholangiocarcinomas as well. But I would refer to the second last slide of Dr. Najam, where it said before involving the interventionist, please make sure you have spoken to your palliative care team as well. So that's what the gist of my talk was going to be. But luckily for me, I think hearing from what has been discussed, most of what you would do in terms of palliation for liver cancer and long-term liver disease has been discussed. So my focus is only to be on the last spectrum, which is end of life care. And alongside that, due to my personal interest in the field, I'm going to start with a few issues of, it's very easy for us to sit here, discuss modern methods of palliation, but we have to be aware of what is available in Pakistan and what isn't. There's no point of me standing here and teaching about multiple opioid usage if there is non-availability in the country. So I'm going to focus on what is mostly available in the country. So the WHO definition of palliative care, we are all aware about it. The major aim of palliation is actually relief of suffering. And it has to be a holistic approach. It doesn't need to be only physical symptoms only. You also have to be very aware of the spirituality of the patient and their emotional and psychological state. And there are multiple examples I can quote from my practice in which how the psychological state was actually affecting symptom management. But obviously, in the interest of time, I'm not going to go into too much detail of that. The only message from this slide that I want to give is that palliative care is not only about physical management of the symptoms. Yes, you can put in a drain and drain the bilirubin, drain the bile and bring down the bilirubin, but that may not always result in palliation of symptoms, because palliation of symptoms will then involve psychosocial care, will involve looking at the emotional burden, will involve addressing other issues that the patient is facing because of this disease. So coming about palliative care in Pakistan, generally, it is not really prioritized. I mean, I'm ecstatic today that the organizers of this conference thought about involving palliative care in a conference on Hilar cholangiocarcinoma. Otherwise, you have cardiology conferences, you have chest disease conferences, you have heart failure conferences, COPD, asthma conferences in this country. And in 16 years, I can recall only about 10 or 12 such meetings of 16 years of practicing palliative care in Pakistan, where I've been involved to come and discuss palliation in non-malignant situations. So most people think palliative care is all about malignant disease. It isn't. Palliative care is involved in all chronic diseases and is extremely important to be prioritized, which is not the case at Pakistan at the moment. There's only a handful of hospitals that are providing palliative care. So that is, to start with, that's the biggest problem I think in Pakistan we have with palliative care. There's limited medication availability. On my fingers in opioids, the only opioid we have is parenteral morphine and long-acting morphine. People who have practiced in the West or who are from the West sitting here or listening to me online will be shocked to know everything else is illegal to bring in this country. Oxycodone, hydromorphone, fentanyl, nothing is available. And it's extremely difficult to practice palliation without access to these medications. There is no specialized training programs, and palliative medicine was not recognized as a specialty till 2022 January, where after about 8 years of negotiations with College of Physicians and Surgeons of Pakistan and a lot of support from people outside Shaukat Khanum, eventually we were able to, in January 2022, get palliative care recognized as a specialty and start a fellowship in palliative medicine. And this slide is essentially talking about how Shaukat Khanum has tried to address this issue in the country and how we have made it a point to make sure that we get people to know about palliative care. So my request to all of you doctors sitting here is to realize the importance of this field, to realize that finally we now have a training ground, we have a facility, we have a fellowship recognized by College of Physicians and Surgeons. It's a second fellowship that you can join after doing your FCPS in medicine or family medicine, as it is the case in the UK, where you join your specialist training in palliative care after doing internal medicine or family medicine. And therefore, I would encourage people to apply for this fellowship because it is the need of the day in this country. So we need to introduce palliative care in undergraduate and postgraduate curriculum. We need to increase the training opportunities. At the moment, Shaukat Khanum, Lahore is the only approved training site for palliative medicine fellowship, which is not enough. In fact, painfully enough, when the first objection that CPSP had for not approving palliative care fellowship was that I was the only person who had applied to become a supervisor. And they blatantly said to me, what happens if you die and you have 3 trainees? So we won't have anybody to continue. And this was the answer I got from in a council meeting. So at least have one more person. I said, well, thank you very much for reminding me. As a palliative care physician, I have to be very cognizant of my own death. So I then asked somebody from Karachi, who's a palliative care physician in Aga Khan, to join hands on that. So, which I think was a very valid point from their perspective. So I'm not complaining, and not at all, but the other thing that is very important, a lot of you are people high up in your field. You're sitting in council meetings with the government, outside governmental agencies. So please, I would request, WHO Essential Lists for Palliative Medicines is a very easy list available on Google. Anyone can download it. Not even 50% of those medications are available in this country. Please, anybody who's sitting in those forums where these political decisions are being made, I have tried my best. I have knocked at every door with friendly and unfriendly governments, but I have not made any headway to this. If anybody has any ideas, I would be quite keen to listen to them. Oh, I talked to Faisal more than once. I knew you were going to say that, Dr. Najim. We've done everything. Trust me on this one. So coming to end of life care, what is the definition of a good death? A good death is probably going to be defined differently for everybody. I think everybody will have their own concept of what they would want to be. But I think if for a moment we can all stop and just imagine, where would we want to be when we are breathing our last? Would we want to be in an ICU with 50,000 tubes around us? Would we want to be in a ward amongst people we don't know? Or would we want to be lying comfortably in our home, in our bed with our loved ones around us? So this is again very difficult question to answer. It would depend on the scenario. It would depend on where things are. So it's very difficult to define a good death. If you go on Google, there'll be probably 5,000 definitions of what a good death entails. And I think it is something that every patient has to choose for themselves. And in my consultations, that's my discussion with them. What is their concept? How do they want to be, or where do they want to be when that time comes? And that's an important discussion to have with your patients. So I'm going to quote Dame Cicely Saunders here, because she's the primary person. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. It is most important, so that with this chronic disease, when you stop treatment, there is a window period of about at least 3 to 9 months or 1 year, where they will be coping with this chronic disease with no curative treatment going specific for that disease, where all these things like the palliative stenting, like making sure they're not going into encephalopathy again and again, they're not having variceal bleeds again and again, all of these things, what prophylactic medications can be given is very important. So it would depend on the disease you're treating. When it comes to end of life, the most important thing, first of all, is having that discussion, which is something we all avoid, because as doctors, we are all trained that death is seen as a failure by physicians. Death is a physiological process, not a pathological process. Everything that is alive has to die. So once we start imagining it as a physiological process, only then we'll be able to hold these discussions frankly with our patients as to when we feel we are at a stage where we need to have valid discussions, important discussions about how they want to plan, what they want to do, and give them good time frames. I mean, I had a patient, and I'm going to take 1 minute extra to talk about that patient, who actually asked me how much time he had. And I told him it's about 6 months to a year. And I said, I know it's a very broad spectrum to give, but that's where you are. He had stage 4 lung cancer, he had brain mets, everything. But I told him, with your brain metastasis, you might be in a month or 2 months at a stage where you can't make decisions for yourself. That man had sent 2 of his sons to UK to study. He sold his house on 2 canals, bought a 1 canal house in his wife's name. With the extra money, he paid the fees for his 2 sons for 4 years. And he was so much at peace. And then he invested some money for his wife. And he handled his manner in such a way that within 2 to 3 months of this discussion with me, when he told me all this, I was surprised at the planning that he had done to make sure everybody after him was comfortable. And these discussions, this can only happen when you tell patients frankly what is happening to them. so that they can go ahead and do these things. This is all about advanced care planning. Yes, we will be wrong. Even today, after 20 years in the field of palliative medicine, my prognosis is often wrong. A neighbor of mine who I thought would probably not go beyond 6 months ended up living 2 years, and her son resigned from his job in Canada. Every time I would go out in my street, he would be staring at me because he thought I said, your mother's not going to last 6 months, and she was alive. And he had come and started living there, resigned from his job. And I used to feel very guilty walking around him. But what can I do? I just made a prediction that didn't turn right. You should be happy your mother's lived fine. So it's very difficult to prognosticate, and that's why physicians don't want to do that, because they don't want to take that. But we do get it right sometimes, and when we get it right, it's very important for people to plan. Coordination of care among specialties, delivery of high quality care in homes, and then comes to the last few days, which we are going to talk about very briefly over here. This is the end of life. What we have done in Shaukat Khanum is we've developed an end of life pathway. For those of you who are familiar, there was a pathway in Liverpool which had some very bad press called the Liverpool End of Life Care Pathway in UK. Eventually it was taken off, but the pathway, the philosophy and the science behind that pathway is very valid. So what we've done with the University of Liverpool is set up a collaborative end of life care pathway, which we actually implement on our patients. People used to tell me, I remember people used to say to me, oh, nobody will go down that pathway when you talk to them. And at the moment, patients are actually quite happy. They proactively discuss the pathway with us, and we put them on the pathway. The families accept it, and they know what the goals of care are. There's no unnecessary investigations being done, and patients are comfortable and symptom-free. The cardinal symptoms that you have to try and manage are pain, nausea and vomiting, agitation, and increased respiratory tract secretions. And these 4 symptoms came up after multiple meta-analysis that I'm not going to quote here. If you go on worldwide, these are the 4 symptoms that they talk about when they talk about end-of-life care. And in Pakistan, now the problem is, what do you give for these symptoms? Because worldwide, the guidelines for these symptoms, we only have parenteral morphine and nothing else. So if somebody is not settling down with morphine, we have a huge issue. But for pain and respiratory distress in Pakistan, the only thing you have is parenteral morphine. And for nausea and vomiting, we only have haloperidol. Something as simple as cyclizine is not available. So this is where we stand. Parenteral cyclizine is not available. For agitation and fits, we use midazolam. And for increased respiratory tract secretions, we use glycopyrrolate. You can also use hyoscine hydrobromide. Again, we have hyoscine butyl bromide, which is Buscopan, commonly known. Everybody uses Buscopan, but for some strange reason, we don't have hyoscine hydrobromide commonly available. So these are the medications which are available in Pakistan, and that's why I've only talked about them. The dosages would vary. For pain, you would start with a very small dose of about 5 milligrams or 10 milligrams of subcut morphine over 24 hours in a syringe driver. We have syringe drivers in Shaukat Khanum. If you don't have them over here, I would strongly suggest that you get syringe drivers. That is the easiest way of delivery of medications, and their time comes in the last few hours to days to make patients are comfortable. In the end, I'm just going to say that how people die remains in the memory of those who live on. And also, there was an article I recently read that the dead are not going to rise up and criticize. So please make sure you get it right. And it is very important for us to get it right, so that at least we can make sure that people in this country who are suffering from chronic diseases, limited therapeutic options, limited options for treatment, at least can die comfortable. That's the bare minimum our responsibility as physicians towards the country is. Thank you very much.
Thank you, Dr. Haroon. It was really a nice talk. I think we are left with no time, but we can take a couple of questions if you have any. They're online. If you have some questions for international speakers, please.
We also have Dr. Anand Sahai and Dr. online.
Hi, Richard. Can you hear me? Usman here.
I can, Usman. Yep, loud and clear.
Yeah. I cannot hear you properly. Thank you for a wonderful talk. I just would like to have your comment. There is a inclination locally that preoperative biliary drainage might increase suffering in terms of developing sepsis, infection, by performing an endoscopy and placing a stent, number one. Is it because we are more inclined to use narrow caliber plastic stents as compared to metal in your cases? Or is it a sterile practices is not optimized as it ideally should be? And my second point would be, is there any cutoff for your HPP surgeons in terms of preoperative bilirubin levels before they proceed for surgery?
Thanks, Usman. There's a few points there. I think Najam made the point. The data that's out there in terms of actual comprehensive trials is pretty thin. There's lots of meta-analyses that can be that have been used and show some advantage in one direction or the other. The actual quantum of benefit in either direction is relatively limited as well. One thing I'd like to get over is the data is not brilliant for any of these questions. I'm personally quite clear that metal stents give you better drainage. Now that's quite clear from the literature. It's not some gem of wisdom. It's obvious. You can see the amount of drainage that you get with them. But there's devil in the detail as well. And I think poorly done or suboptimally done, let's choose my words carefully, drainage is worse than no drainage. And I think the continuing debate about percutaneous versus endoscopic, and it will become EUS as well shortly when there's more robust data around, it can spin in any direction really in terms of what you want. But when it's done poorly, you will be better off without drainage. Coming to the surgical cutoff, I think it's the practical issue about drainage is the length of time that it takes to work a patient up for surgery. And somebody who arrives or presents with a bilirubin of 100 micromoles, anyone who works in milligrams will need to convert. In 3 or 4 weeks' time, it's going to be 300 or 400. And I think the data for surgery when you get into the higher levels of bilirubin is that there is significant morbidity from operating in that situation. Yeah, there is a cutoff. I think we will get some surgery done with lower bilirubins without drainage, but the majority of patients are going to end up with drainage. Thank you.
Thank you.
Any more questions, please?
Yeah, just a question to Dr. Anand Sahi. In your experience, what would be the best approach, or where do you find those lymph nodes in cholangiocarcinoma? Usually you want to go periportal from the duodenum or transgastric?
That's a great question. So they're in the hilum usually. Celiac nodes I find are quite rare. I would say that if you're looking for nodes in the hilum, there's two places to see them. One is from the stomach, because they're on either side of the portal vein. So if you go from the stomach and find the liver in the stomach, and then localize the portal vein and follow the portal vein out of the liver, the nodes on one side of the portal vein will be directly in front of you, and you can sample those quite easily. And the scope is in a straight position, so it's quite easy for the patient, and you're very close. Then the other place to go is in the duodenum, in the bulb. Find the portal vein in the hilum again, and you get the nodes on the other side from that station, and you can sample them there as well. There's really not much use in going to the second duodenum to see nodes in the hilum, I find. So it's basically the two stations, one from the stomach and then one from the bulb. And just look around, and I say any nodes that are present, because actually you should never have nodes in the hilum, in my experience, unless there's a reason. Either you've had a cholecystectomy or an ERCP or something, but basically any nodes in the hilum are abnormal. And in cholangiocarcinoma, even the benign nodes can be positive, so it's worth sampling them.
Just to follow up on that question, usually these nodes are small. I think that's our observation also. So you have any tips or tricks to get a more yield? Because the smaller the nodes, the sort of needle doesn't move very well in it, especially if you're doing transgastric, it just pushes away when pushing in the
Yeah.
needle?
So, well, I find Hilar nodes are usually not that mobile, but if you are having trouble, especially with the new FNB needles, certainly the Francine tip, it can be hard to get through the gastric wall initially. So I think the trick there is to focus on first, don't try and get into the node immediately. The first thing to do is get the needle through the wall. Just focus on getting through the wall, then reposition yourself, put the tip of the needle up against the node, and then use what Rob Hawes calls the shish kebab technique to kind of quickly puncture through and go through the node. I think the important thing is to really go through the capsule and really go through the entire node. For solid lesions, as I pointed out, I don't use suction because it causes blood. But for lymph nodes, I actually do use suction because there I'm still putting it all in the formalin and we're not doing Mohs. So the blood isn't really an issue. And you do get more tissue with suction. So with nodes, I do use some suction. What I do is I use the suction syringe. You know, we prime it and then I put it on, attach it to the tip of the to the needle. But instead of doing continuous suction, which I think produces a lot of blood, once I puncture through the needle and move a few times, okay, through the needle, through the lesion, I stop. I just open the suction for a second or two and close it, just enough to pull the sample up into the needle, and then I do it again. And I think the important thing is to go through the lesion, come out of the lesion, completely come out, but stay behind the wall, and go somewhere else and go through the capsule in a different place. That way you know you're really getting fresh tissue from all through the node. So going into the lesion, staying there and just moving around and then trying to fan and go somewhere else without coming out of the capsule, I think reduces the quality of your sampling. You go through the capsule, sample deeply all the way through the node, come out of the node, use the elevator or the up down and go somewhere else and go back through the capsule and go all the way through the node in multiple places. And after each time you've done some movements, open the suction a little bit, then close it.
The preference for any caliber of the needle?
Yeah, so we use exclusively now the 22 gauge. The 25 gauge Francine or the Shark core, which are FNB needles, really don't produce great cores. So there's no advantage for them. They're actually good cytology needles, but for core, if you want histological cores, pretty much everybody agrees that the 22 gauge is the best thing to use. It gives you good cores and it's quite flexible, so you can use it in any position: D2, bulb, scope, long position, short position. The 19 gauge FNB needles do give you a lot of more tissue, for example, for liver biopsy. But there's no advantage in terms of the yield for cancer. And in Canada, it's 4 times the price of the 22 gauge. So we just don't use that 19 gauge FNB needle.
Last question, sorry. Do you have any comparative data looking at the laparoscopic assessment before the surgery and versus an EUS, looking at the nodes there? And, you know, because if that is there, one might actually perform an EUS rather than an laparoscopic examination before going for a surgery.
Yeah, I don't know of any certainly prospective comparative data. In our institution, I think they almost never do laparoscopy. It seems to me in these patients, certainly our patients, you know, if they're jaundiced, they're getting an EUS first and then probably an ERCP. So laparoscopy would be the last option. But as I say, if you find, for example, unexpected ascites or something, I think that's where we would use laparoscopy. But as a primary staging, I don't think we would use laparoscopy. But there are no data that I know of.
Anand, I have a question for you. We obviously performing EUS and FNB for most of the solid lesions and the lymph nodes, but sometimes we are asked to do a biopsy from the gallbladder lesions. What is your experience of safety of performing FNB for the gallbladder lesions, particularly the risk of leakage from the gallbladder? And what would be your preference needle size in that case?
So we only will biopsy the gallbladder if there's really a significant mass component. If there's just some thickening of the wall and then you've got, bile on the other side, I won't biopsy that. It has to be a significant mass component. So that's why in our experience, we haven't really had any leaks to my knowledge because we focused only on going when there's really an obvious mass component. And even in those cases, if there are nodes, we'll go for the nodes first. In some cases there, having rapid on-site evaluation may help. If finding, for example, the node is positive, then you don't have to do the gallbladder. Or in some cases where the patient looks like they might have an operative lesion and they're going for ERCP right after, if we tell them the node is positive, then they become non-operative candidates, certainly in our institution, then they'll decide to put in, full metal and treat, stent in with a palliative, long-term palliative goal. But that's quite rare. And in those cases, you can use, you can do a touch prep with a FNB sample to get cytology, or in some cases, then we'll just use a 25 gauge cytology needle and just do regular cytology like we used to, but that's quite rare.
That's great. Thank you.
In the interest of time, I think we're going to close the question hour session. And thank you, Dr. Anand Sahai and Dr. Richard Sturgis for being online with us. If the chairs would like to conclude the session.
Thank you.
Thank you. Great talks. I wanted to ask some questions as well, but I think there have been too many questions. Everyone was really interested in these talks. Thank you very much.
Thank you. Thank you, everyone.
We will conclude the session
Thank
here.
you.
And thank you, Dr. Richard and Dr. Sai. Thank you very much for sparing time and sharing your experience. So we'll move to the next talk is by Dr. Professor Faisal Saud Dar, Dean of PKLI, and he will talk about the national guidelines regarding hilar cholangiocarcinoma. Dr. Faisal Dar.
Okay, thank you very much. I think it was 2 very productive days. And actually, we are loaded with knowledge by now. On one side, I have learned a lot, but on the other side, there are more questions to answer now. I think the purpose of organizing this conference was that cholangiocarcinoma has never been discussed in our routine gastroenterology meetings, at least to the best of my knowledge. And the patient I normally see is coming through the surgical route or a gastroenterology route with no clarity that how these patients should be managed. And actually, this is the same even today after having this consensus meeting. And the area which are unquestioned probably remain the same. So I think it was great to learn from all of you. And thank you all the participants and the speakers who come all the way. I just want to conclude this with this consensus statement. Although this is not finalized yet, we had a long day yesterday with experts presenting on their topics, and the purpose was to come up with the national guidelines. So we have a very basic draft by now, but what we are going to aim is that in the next 4 to 6 weeks' time, we are going to finalize this draft and then circulate with all the authors, and then eventually prepare the final manuscript to be published in our national journal. So that will probably give a guideline for all the people who are involved in the management of cholangiocarcinoma. Okay, so the Oxford Center for Evidence-Based Medicine is our basically benchmark. All the evidence which has been collected and quoted by different authors will be gauged on this scale, And whatever recommendations we will come up at the end of this manuscript will be according to this grading system. So, I mean, this is how we have tried to do it. In each area, we have drafted these recommendations. Although these are not final yet, that is why I don't want to share. But what I can give you right now is the summary. So these are the 17 areas which was discussed in the yesterday's meeting with all the speakers presenting their piece of evidence on each and every of this topic, and at the end writing some recommendations. So I can just take you through, like epidemiology and risk factors for cholangiocarcinoma. I think they are pretty much well known, like primary sclerosing cholangitis, hepatolithiasis, choledocholithiasis, and so forth. And one of the rare factors, probably obesity, smoking, and so forth. Coming to the initial evaluation laboratory workup, I think in the lab side, we don't have much of the investigation available. So it is the interpretation of your liver function test and combining that up with CA19-9, and that actually gives you a hint of the diagnosis of a cholangiocarcinoma. And then imaging workup, that probably remains the real standard for us so far. Although we have debated all that in the last 2 days about CT scan or MR or MRCP, which one is the better. And I think you can pull out the evidence on both sides. But CT scan remains the widely available investigation. And even the CT scan technique, which is being done at a district general or a tehsil headquarter hospitals, it is pretty much standardized, because we have to, whenever we write these recommendations, we have to put our local context into the picture. When we are talking about doing a CT scan, which is 4 phases, I mean, you need to have a good technician to do that. And most of your patients who comes with a CT scan, they don't have a proper CT scan. So CT scan, in my view, remains widely available, not only in Pakistan, even in the Western world. And most of the centers still rely on a CT scan. So CT scan probably should be the investigation of choice as a first line, complemented by MR wherever it's indicated after discussion in the multidisciplinary meeting. The next is the initial diagnostic evaluation role of endobiliary procedures for hilar cholangiocarcinoma. Again, we have talked a lot about, and actually we are absolutely loaded with the endoscopic interventions being done so far. But in my view, the take-home message from the last 2 days is that sampling the hilar cholangiocarcinoma in each and every patient is neither possible nor recommended. So the cases should be discussed in the multidisciplinary meeting, and based on the discussion on the radiological images, there should be a select of a patient who should be exposed to endoscopic procedures for the tissue. Histological classification is pretty much simple. Most of these tumors are actually adenocarcinomas. However, increasingly, we are seeing biliary intraductal neoplasms and biliary intraductal papillary neoplasms. Very rarely, you can see squamous, adenosquamous, and neuroendocrine tumors of the biliary system as well. The other part was the staging. That was also discussed and debated in detail. And by and large, the message is that Bismuth classification still remains the standard as long as you are going to establish the extent of the tumor along the biliary system. However, the limitation is that the Bismuth system does not include the vascular involvement and neither the future liver remnant. And these two are basically the important information which are required in terms of planning the management of the patient. So Bismuth, along with the Blumgart classification that is based on Memorial Sloan Kettering Hospital's classification, in combination of the two, probably will be the best way of using the staging system. The TNM staging system preoperatively, it actually doesn't matter. It is more relevant in the setting of staging the tumor and designing the post-operative treatment. Definition of resectability, I think the message was very loud and clear. The resection basis, I think there are two basic pillars. One was that the tumor should be removed completely. And secondly, you need to have enough liver behind in the form of a future liver remnant. As long as a surgeon or an institution can completely remove the tumor based on their local expertise, and they can ensure enough future liver remnant, either with or without liver augmentation procedures, should be the way forward. And that is how you define the resectability of the tumor. Preoperative portal vein embolization, again, cannot and should not be used in each and every patient of hilar cholangiocarcinoma. Again, the patient should be discussed in the multidisciplinary meeting and define the resectability first. Defining resectability, you have to look at the future liver remnant. And if the future liver remnant is less than 20%, definitely you will require. If it is more than 20%, then actually you need to look at the age of the patient, the quality of the liver, and so many factors. And the portal vein embolization actually can be done. The other liver augmentation thing which were discussed in different meetings was the ELFS procedure. I think this procedure has been over-described, still carries a very high mortality and a very high morbidity and a very, very selective indication. The next was preoperative biliary decompression for hilar cholangiocarcinoma. I think we have debated a lot about the cutoff level of a bilirubin. In my view, that is actually not important. I think you have to look at the patient as a whole and your institution, the way you are going to offer the treatment to these patients. In my view, working in the United Kingdom and here in PKLI, majority of the patients who are resectable end up having an ERCP and a stent inserted because you actually cannot accommodate them on the surgical list in the next week or 2 weeks. So if somebody comes to you with a bilirubin of 7, 8, and you cannot accommodate them in the next week, probably they are going to end up having an ERCP. So it is either the institutional lethargy or the patient's unwillingness right at the upfront not to go for a surgery. I think that actually determines that the majority of these patients end up in having biliary stents. However, there will be patients where bilirubin should not be considered as a cutoff for putting a stent in. I think majority of the data quoted for bilirubin as a marker for post-operative mortality was from the 90s. I think the hepatobiliary surgery has really evolved from the mid-19 onwards. So the resection, which were never possible in those days, are getting possible. So I think that we actually need to address when we are writing these recommendations, and we will look in a bit detail to this, that what the literature says. Preoperative biliary drainage in using PTC. I think again, the data represented on both sides were very interesting, very exciting, but I love Dr. Najam's talk if he's still around, because majority of the speakers in the last 2 days, endoscopic versus PTC, they were talking about the stent patency, bilirubin coming down so quickly or not. I think Dr. Najam, what he touched about was, and Dr. Richard Sturgis, I think they have an absolute clarity that when to do and what to do, and most importantly, when not to do. And the message was clear from both of their talks. If you think by putting a stent either endoscopically or via PTC, you are going to improve the patient's survival, only then we should do it. Otherwise, it's better that the patient should die with peace and dignity rather than having recurrent cholangitis, repeated stenches, and dying with misery in a hospital as an outcome of biliary interventions. I think, again, it is very clear in my view for bismuth 1 and 2, endoscopy, in my view, is far superior, should be preferred. For bismuth 4, probably 3, PTC, endoscopy, you can debate. But the other thing which we need to keep in mind all the time, although PTC is nice and quick, but if you have put a stent in, and then these patients' bilirubin comes down, these patients are going to survive a bit longer, but the morbidity of the PTC is humongous. So even if we have done PTC as a first step, I think maybe 2-3 weeks down the line, we should do a rendezvous procedure and convert into an internal stent. That, in my view, is a better way of a palliation. But writing down the recommendation, again, we will look into our local circumstances and the piece of the evidence we have. Then was oncological therapy for patients with locally advanced and metastatic cancer. I think the answer was very crisp, that you have gemcitabine and cisplatin as a first-line treatment for patients with irresectable and metastatic disease. And if there is no response or disease progression, then you can go for a second line that includes fibroblast growth factor receptor blockers, or in terms of immunotherapy, you can have checkpoint inhibitors for this metastatic disease. A surgical resection for cholangiocarcinoma, I think, again, the message was very, very clear. Whenever you can resect with the aim to get an or not resection, that is the way forward. Whether that include a portal vein resection or an arterial resection, with or without portal vein embolization, with ALPS procedure, or whatever. I think that all depends on the local expertise of that center, and they can make a plan according to the local expertise. Liver transplantation, again, the message was very clear. Liver transplantation should only be reserved for irresectable hilar cholangiocarcinoma, or where you cannot achieve a or not resection. The basis for liver transplantation in hilar cholangiocarcinoma Mayo Clinic protocol so far is the only piece of evidence for us to have a guidance. But in our country, we don't have brachytherapy, and the way our health system and the transplant facility is designed, I am sure that we won't be able to follow the Mayo protocol. So what we need to do is we need to come up with a new protocol which is doable, like starting with some sort of a new adjuvant chemotherapy followed by liver transplantation. And that protocol should be followed by all the centers. And that was discussed yesterday. And one of our colleagues has been designated as a focal person to develop a protocol. And this consensus group will have a debate. And hopefully that will be the way to start a liver transplantation. The other view, my view about liver transplantation, I think whatever the US results are, you have to actually take it by the pinch of salt, because that has never been reproduced by any center in the world. And there is hardly any data from the Asian world in the form of a living donor transplant from hilar cholangiocarcinoma. So that will remain an area of trials, I think, for the good few years to come. Next is surveillance protocol for after surgery and transplantation. I will just talk about surgery. I think there was a very nice discussion yesterday that based on the patient's outcome factors, like the size of the tumor, the grade of the tumor, lymph node involvement, and perivascular involvement, and perineuronal invasion, plus the CEA level, you divide them into two groups, high grade and low grade. For high grade, you follow them up every 2 to 3 months with a clinical examination, LFTs, and ultrasound for the first 2 years, and then every 6 monthly with a CT scan every 6 monthly for the first 2 years, and then annually. For a low risk group, the clinical examination and ultrasound is for 3 months for the first year. CT scan is twice a year for the first 2 years and then once a year. So I think that is also pretty much straightforward. Post-operative adjuvant therapies for hilar cholangiocarcinoma, I think that is, I have already touched about that. No, sorry, you talked about metastatic cancer. For this, I think gemcitabine and 5-fluorouracil, which has been there for the last 30 years, is probably the same. Then is a neoadjuvant therapy in the setting of liver transplantation / resection. I think neoadjuvant, we need to come up with a new protocol, as we don't have any guidance apart from a NEO protocol in the setting of transplantation. In the setting of surgical resection, again, there is no standard protocol yet. And lastly, palliative care for hilar cholangiocarcinoma. I think that is an area where we have to think, because in Pakistan, 85% of the patients with hilar cholangiocarcinoma come at a point where palliative therapy is the only way forward. And the palliation involves, the biggest palliation, actually the need, is the drainage of the biliary system, because that is what is leading to the real morbidity. And in the palliation, if you want to improve your survival, the only survival you can improve is with a bit of a chemotherapy. And the chemotherapy can only be given if they have a low bilirubin. Which patient will require endoscopic or a PTC? I think we have already debated that. But once the jaundice is settled down, they need to go for a chemotherapy. With irresectable hilar cholangiocarcinoma, which is metastatic, I think the median survival for these patients without any cancer treatment is probably 3 months. And if you are going to give them a chemotherapy, you are going to maybe make them live longer for an extra 6 months to 1.5 years. So that 1 year of extension of survival is all about biliary interventions and chemotherapy. And that brings me to the last part of the palliation, which is an end-of-life care. I think that really has to be synchronized, considering our social setup, the resource limitation, and the expertise available. It may not be a good idea to keep treating these patients and making their life miserable because we can stent them and because we can give them a chemotherapy. I think at some point in time, we do need to decide when not to treat them and actually making them die earlier with dignity rather than dying a bit later with absolute misery. And I think that remains a very personal decision for the clinician and his approach to end of life, and the family, how they want to take this process forward. With this, I think that's the end of this conference. And I just want to thank you everyone for their active participation.
Thank you, Dr. Faisal. That was an excellent summary. I'm just going to end by thanking our sponsors. So we have AllMed, Himal, Ferosans, Boston Scientific, Cook, and Fusion, who helped us in doing this conference. I'd also like to thank the PKLI administration that did a very good, excellent job, the transport department, the audiovisual team at PKLI, and the food and nutrition department. And thank you all for staying for so long. It was a great conference. Tea is going to be served on the left side. And just one thing, this is a 12 CME accredited activity by UHS. So please make sure that you've signed for both days and that your email and all the details are there so that UHS can send you a certificate and that you can get those 12 CMEs. So we will email you your CME certificates. The certificates that you see are participatory certificates from PKLI, but not from UHS. So thank you very much. And we hope to see you next time at the next collaborative PSSLD and PKLI meeting. Thank you.